Good morning, everybody. Hi, Aditi, Tanvi. Hi, Monica. Hi, Riddhi.
Good morning, ma'am.
Rikisha, could you just spotlight the students, Tanvi, Riddhi, and Monica and myself?
Yeah, one second.
Thank you. In case anybody of your friends or anybody whom you have sent the link to are having challenges, I am sharing the link again. So please contact because some people are having technical issues.
Ma'am, I need the controls. I am not the co-host.
I can't hear you.
Ma'am, I need the controls. I am not the co-host yet.
Yeah, so Rikisha, please could you make Riddhi, Tanvi, and Aditi and Monica co-host here. Hello, Sushila ma'am. Sorry for the technical issue. They're all still growing technically. Hi, Rajisha. Sorry for the trouble.
It happens.
Hi, that's all right. We've all faced the same issue.
Absolutely.
I really
Hi.
wish, it just
Hi, Rajisha.
sails through
Hi, ma'am.
peacefully. Nikisha, you can show yourself. I'm sure all of us want to see who's
It's okay, ma'am. Ma'am, can you just mention in the chat who all needs to be this spotlight?
Yeah, so Tanvi Ketkar,
And
Monica Verma, Aditi Lotankar, right? And Riddhi is already on
Yes.
spotlight. Okay, requesting all participants, apart from the speaker, including speakers, to just type your name and your profession or what you do, because we are just taking a small attendance, like how we do it in workshops. So first 5-10 minutes, we want to just run through the attendance. So quickly in the chat box, I want you all to type your full name.
anyone else for spotlight?
No. Monica Verma and myself, and that's about it. 5 of us. As of now. And you need to give host rights to Sushila ma'am and Rajisha. You can spotlight them also, sorry. Please spotlight them as well. Rikisha, is it possible for me to share an Excel sheet on the chat for people to type in directly? Is that
You can
possible?
send the link of the Excel sheet.
Of the Excel
Is
sheet.
it
Okay,
what do
people
we
are
say?
typing.
Is
So,
it a drive file?
no, it's a
Normal Excel sheet.
normal Excel sheet. Okay, so I will put it on the drive. You say that's better, right?
Yeah.
I put it on the drive and share it. Okay. So then they can fill.
Yes, ma'am.
Thank you so much.
Ma'am, just share the drive link, then they will be able to fill.
Okay. Until then, we'll start. So, good morning, everybody, and welcome to day 4 of the wonderful event that we've been hosting since last week, called Including You. Now, Including You is an initiative by Cheerful Connect, which is basically a platform which engages in interactive, proactive interaction amongst people who are working in the space of disability. It could be, when I say working, I don't mean just employed, but also parents, people who are support groups, people who are, building awareness. So it could be anybody who's touching the lives. And now, if you see, we are 46 of us who's probably here touching the lives of the world of disability and trying to see what we can do. Maybe some of us are here uh, to expand our knowledge. Some of us are here to contribute to it. Some of us are here to, for the first time to get that feeler as to what it is. Because, as a special educator myself, I have also had inhibitions and judgments for a very long time till it started wearing off with my experience. So it is not easy for somebody to say that, okay, let's come on, let's become inclusive and just come into the whole space. But it takes this little moment that you have made a decision, and we are so thankful to each one of you that you took this decision to be here on a Monday morning and participate in knowing that little bit more along with all of us. And it is really amazing that we've had such wonderful people who have accepted willingly, gratefully, to be part of this. And today we have Sushila ma'am, we have Dr. Rajisha, we're going to be having Saraswathi ma'am. So, and maybe one more speaker would join them. So it just goes to say that though they are busy in what they do, though they are doing so much more for the sector, for the people's wellness, today they are ready to take the time out so that they can share their knowledge with us. So, let's really welcome with a nice round of applause. And it's really, really a
Thank you,
wonderful.
Arpita.
Yeah, thank you. Thank you. And without taking much time of all of you, we will be starting with our session. So if you have any questions, reserve them for, a little time later so that we can, interact with the speakers. For now, again, I'm just repeating as people are joining, kindly drop your name and your profession or what you do. You may be a parent, you may be an employer, you may be a student. Please drop that in the chat box for us to record your attendance. So we just want to take note of it. Thank you so much. And in case any of your friends are having any trouble with the link to join in, message us immediately so we can respond to you. Thank you all. Yes, so ma'am, we have 3 amazing campaigners. I call them campaigners because they have taken this literally in no time. So they are students of Dr. BMN College, Riddhi, Aditi, and Tanvi. They are second year students in nutrition. So you'll be very happy to know they're here to listen. They've been here all along and they are here gathered specifically for today's session as well. And these kids, I must tell you that it gives me great joy that, okay, I come from the sector. I have worked for about 20 years. There is little bit of, sponging that has happened in my life. But for these kids, living in a very, that college age and that time, the minute I requested that I need some volunteers to support me in this journey, Dr. Mala Pandurang, who's the principal of Dr. BMN College, immediately got me these 3 kids, and I was like, wow, this is like prayers answered in no time. And when I spoke to them, they were more than enthusiastic to, make every day very, very interesting, very creative. In fact, the first day we got an introduction with Riddhi singing a song of the entire agenda. So it was so interesting, and we have something for you all today as well. So kids, you might switch on and say hello to ma'am and Dr. Rajisha. So yes, so they are literally the pillars of this session, ma'am. And of course, we have Rikisha from the college who's supporting us completely. Okay, so I'm going to hand it over to the kids. My job is over. So it's all them. Yeah. So, ma'am, do we have Saraswati ma'am joining in now or later?
No, she'll come at her time. She has her sessions now.
Fair enough. Fair enough. Okay, so kids, make a note of that. So let's start. It's all yours. All the best.
Thank you. So should Rajisha start?
No, the kids will first introduce you
Okay,
all.
okay. Sorry, I thought you said start, so whether we have to start. Okay, okay, okay.
Good morning, everyone. So we have a short video on nutrition and its significance in life that we have prepared by ourselves, along with a video that was put up on the internet by WHO. So let's have a look at it.
Hello, Aditi.
Hey Riddhi, do you know I came across this fact recently that there is increasing international interest in the links between malnutrition and disability. Both are major global public problems. Both are key human rights concerns and both are currently prominent within the global health agenda. In this review, interactions between the two fields are explored, and it is argued that strengthening links would lead to important mutual benefits and synergies.
So, does that mean nutrition is extremely important for one's lives?
You're absolutely right. Let me show you something.
Nutrition is important at every stage of life. From the early years, optimal nutrition ensures children grow and thrive. School years are an important time to develop healthy habits. And these smart decisions should always be encouraged to ensure health and well-being for all at all ages. Nutrition is particularly important at some stages of life, like during pregnancy. For enjoying a long, healthy life, it is a good practice to have regular checkups and eat healthy diets. Optimal nutrition is one of the greatest gifts you can give yourself and your loved ones.
That was quite helpful. It means good nutrition is adequate, well balanced diet combined with regular physical activity, while poor nutrition can lead to reduced immunity, increased susceptibility to disease, impaired physical and mental development, and would also reduce our productivity.
Exactly right, Riddhi. To improve our knowledge in nutrition and health, especially for disabled people, we have phenomenal speakers out here.
Yay! Miss Sushila, Dr. Rajisha, Mrs. Saraswati, Miss Sapna takes lead. Let's get true insights from them. That's our plead.
That was lovely.
Thank
Absolutely
you, kids.
lovely. Wonderful girls.
They have been consistently doing something creative every day on some topic. And I can't tell you, ma'am, I have just shared one line or two lines with them. And they work through the night, apart from their college work and everything. And they send me, and I feel like, wow, my day is going to go so well tomorrow. Thank you so much, guys. Thank you so much, all three of you. Yes, so let's have introduction for Dr. Rajisha. I think she's going first.
Ma'am Riddhi will
So,
be.
yes.
Aditi, can you please share the screen? Dr. Rajisha Shah, a physical therapist with 5+ years of work experience in treating differently abled children. She has a master's degree in neurology and runs her own setup in Ghatkopar East by the name of Sun Physiocare, which follows an holistic approach in rehabilitating children with special needs. Her passion towards quality healthcare for the society led her to run a YouTube channel that helps people upscale their health in collaboration with other healthcare professionals. She has given several talks over the time in schools and colleges and is currently mentoring other physical therapists interested in pediatric physical therapy via mentorship programs. Finally, she is a Pilates enthusiast and an instructor. Ma'am, it's our honor that you are part of this. We extend our warmest welcome.
Thanks, Riddhi. Thank you for such a lovely introduction. I am pleased to be a part today here amongst the student, the faculty, and the parents of the children, even the therapists that are present here, and my colleagues that are also a part of this talk today. It gives me immense pleasure to be able to share my knowledge to the aspiring candidates for who are interested in the field of healthcare for differently abled children. Given that, let's dive deep into the first part of our talk today, and I'll be sharing my screen now. Just a second. Mm. Yeah, I'm sorry, I didn't share. Share. Great. So today's topic, what we are looking at is neurodevelopmental issues affecting feeding and nutrition in children. I'd like to make this interactive. Of course, I do not expect you to unmute yourself and talk, but I'd like some inputs from your end, or if the cases that you've seen in your day-to-day lives, if you want to add something about it or share your views, please feel free to type in the chat box and I'll go through it when we have a Q&A series going forward. What we are going to cover today is growth assessment in children. That is growth. We are looking at why growth is important in children. Assessment will be covered later on. Eating, feeding, and swallowing definitions. Essentially, what is the difference between these three and what are we looking at? What is the anatomy and the function of these? So given that, what are the indicators of feeding issue in the children? The conditions that we will be covering is cerebral palsy, syndromes, ASD and ADHD, a multidisciplinary approach, clinical evaluation and interventional strategies, case studies, special needs for special needs, and importance of yoga for children with special needs. Why do we eat? So anybody with any feedback, why do we eat? You can type in the chat box, I'll go through it. Why do we eat? Okay, so just a second. We eat for survival, experience, and growth. Survival comes from nutrition and energy. What we eat determines our energy levels. Determining our energy levels also means that it results in our growth. When we look at the height and the weight of the child, when we look at the body mass of a child, which is BMI again, which gets into the picture, we look at the growth of the child overall holistically, and hence the mind comes into picture, and experience, emotions, and bonding. So we don't look at eating just as, you know, food going into the mouth and then you're swallowing it and you're becoming healthy, but we look at food as something that has various components involved in it, like survival, experience, and growth. And likewise, even the emotions that go into it, even the experiences that you encounter when you are eating, those are equally important. That is when we refer to the cognitive and social components of the food. So that is equally important, and we have to pay attention to it when we are dealing with our children. Why do we need to understand growth in children? The basic thing is that, again, coming to the same thing, the growth is responsible when you're looking at a development of a child at different age groups. We know what growth to be expected at a certain age group in a child. And if the child is not following that parameters that are expected in the children, they may be lagging behind. And given that they are lagging behind, there is interventional approach that we have to follow in these children to make them at par with their developmental age. If they do not follow in that developmental age, what happens is they may be encountering various issues in participation. Participation meaning what they are doing in the society and in the community. So their vocation, that is their profession going ahead, what would they become in life, or looking at their peer participation when they are children, how they are contributing to their friend circle, all of these gets affected. And how nutrition plays in a role in it, it plays a very big role in it, because food is our basic source of growing and developing into an adult. Not only does it involve physical components, likewise emotional, cognitive, and social. So we are looking at the overall development. What I mean to say is food is not just with respect to physical, it is also with respect to emotional, cognitive, and social. We look at the interaction of all of these factors in order to bring about a development in a child. So, what are the challenges that are encountered by children with special needs? There are a lot of challenges which children can encounter. Like, I'm covering conditions one by one, but although to give you a brief picture of what problems this can lead to if the child is not adequately developed, is altered energy and nutrient needs, delayed or altered growth patterns, feeding delays of oromotor dysfunction, elimination problems. That is, they may have either a lot of loose motions, diarrhea, or either constipation issues, which are very common, leading to overweight and obesity. Medication nutrient interactions, even the medications that they consume can have an impact on their nutrition. There is a very famous quote here that goes that when your diet is right, there is no need of medications. But when the diet is wrong, there is no use of medications. So your diet has to be right in order for your medications to be subsided. The doctors, the pediatricians that you go to will definitely look at the diet that you're taking and may minimize the medicines intake that you're looking after or taking in. Appetite disturbances, either that can be over increased need to eat more, or a decreased appetite or decreased need to eat, unusual food habits, and early childhood caries and gum disease. Why focus on feeding and nutrition? Height and weight, gross and fine motor function. So this is where we come into picture as PTs and OTs. This is one of the major things we look at: gross and fine motor functions. How the child is eating, how the child is sitting, what is the position of the child? Is the position optimal for the child to chew, for the child to bite, for the child to swallow? Are the positions optimal? Is the child sitting properly? How the child is using the food? How are his fingers? Is it too messy, or it is optimally messy? The child is able to cut the food into pieces and take it. This is where all of these comes into picture and we come into picture. Cognitive and social. So when we look at cognitive and social, we also talk about the behavioral issues in a child, which I'll be covering in detail in the later part of the presentation. But behavioral issues in these children are quite common in children with special need. Since they do have a lower cognitive quotient, they do come with lower IQ and EQ. There is a possibility that they cannot form that complex and deep understanding with their food and the caretaker. Since the caretaker is equally important in giving the child food, that kind of emotional connection and attachment may not be formed with the child and the caregiver. So going forward, again, growth and development, function, environment, and participation. I already covered participation, why it is important, how food can help in the increasing participation of children. Components in children with special healthcare needs: oromotor structure. We look at the oromotor structure and the oromotor function, and the gastrointestinal issues, sensory issues, and why all of these bring about delayed growth due to physical attributes. Now coming to the differences between eating, feeding, and swallowing. Eating is necessarily a phase in which you're putting food in the mouth and the food is being prepared into a bolus. Feeding is when the food is being actually swallowed, and this is the exactly the part that is extremely important, because there is a lot of integration in it that takes place. There is a food when the food bolus is formed, there is a lot of mechanism that gets involved, in which the children and the caregivers both play a role. So you have to actually facilitate swallowing, you have to facilitate feeding. You cannot expect a child with a special healthcare need to just feed themselves. Since they have so many physical and developmental abnormalities, it is difficult for the child to feed themselves. We have to facilitate it. And swallowing or deglutition includes the entire act from food placement in the mouth until the material enters into the stomach. So when we talk about eating, we don't say that eating is the same as essentially eating and then the food goes into the intestine. We talk about eating as just the oral phase. Feeding is necessarily the pharyngeal stage, and swallowing is necessarily the esophageal stage. So I will be explaining this in detail. When we look at this, we say when the oral stage, what is the oral stage? The food is put into the mouth. there is chewing, there is mastication that comes into the picture, in which the teeth are involved, and a bolus is formed by mixing of that food with the saliva. So that is essentially a process of mastication and bolus formation. When we go into the pharyngeal stage, the tongue touches the hard palate. Hard palate is your first part of the upper roof of the mouth. So when the tongue touches the hard palate, there is a closure in the mouth that is attained, and the food is pushed towards closer to the pharynx. So once the food is pushed closer to the pharynx, there is closure of nasopharynx, because we don't want the food to regurgitate through the nose. So the nasopharynx has to be shut. So the nasopharynx is shut with the help of the epiglottis. There is elevation of your food pipe, that is your pharynx. And from the pharynx, the food in a peristaltic action goes to your esophagus. So esophagus, once it goes to, from the esophagus, it reaches the stomach. So this is the basic procedure of your your eating. That is, your entire gastrointestinal system takes place in this way, from your food going into the mouth to your pharynx and then to your esophagus in a peristaltic action. What we look at when we talk about this, we look at their lips. Why we look at their lips? Because there has to be a perfect closure of the lips. If the perfect closure and mouth approximation in these children is not attained, there are a lot of chances of the food to be spilled from the mouth. That is not functionally desirable. Teeth. Teeth have to be well developed. Their dentures has to be well developed. We start looking at when the child is developing the front incisors and the lateral incisors. The chewing happens from the lateral incisors. The biting happens from the front incisors. And this is important, because if one of these structures is not developed, the chew will be really weak. And that's not what we want. Tongue. So as the tongue development takes place first in the anterolateral, that is anterior posterior, that is only front and back. As a child is born, he has only this movement. I don't know if you all can see me, but this is the thing. Okay, only front and back. But later on, as a child develops, lateralization of the tongue starts taking place. That is, the child can move their tongue from side to side. Okay, this is important because not only just with respect to your feeding and nutrition, but also with respect to your speech. Often these children, you will see that they have slurred speech. They cannot talk properly. That is because the lateralization of the tongue is poor. And we want all of these things to develop properly. So in our assessment also, we touch it. Palate. Hard palate and soft palate. As I said, the tongue approximation with your hard palate is important for your complete mouth closure in order to put your bolus of food inside the food pipe. So if this is not happening, your hard palate is completely upper, ya completely niche, your tongue is not going to be sticking to the hard palate to close the mouth. It is not going to be functional again, and that proper desire that you want, the proper movement that you want of the tongue and the hard palate will not occur. Pharynx and esophagus. Pharynx is your food pipe, and esophagus is what transfers the food from the pharynx to your stomach. So one thing I want to mention here is aspiration. In children with CP, cerebral palsy, as you may know and you are aware about, and likewise the other conditions, what happens is when the food, these children have poor defense mechanisms. That is, they do not have, what I mean by poor defense mechanism, coughing and sneezing are your defense mechanisms when you talk with respect to your oromotor and respiratory structures. When you are not able to cough or sneeze, your defense mechanisms are low. There is a chance that there is improper closure of the nasopharynx from the epiglottis. It can regurgitate either into the nose, or it can regurgitate directly into your windpipe, that is your larynx. It can regurgitate there and from there go into your lungs. Normally, if it regurgitates, if it goes into the larynx, you are able to cough it out. But in this case, when these children have poor
It's 11 hours.
when they have poor musculature, they are not able to cough it. So what happens from their larynx? It goes into their lungs, and from that lungs, it results into aspiration. That is aspiration pneumonia. Affecting the respiratory system may cause respiratory failure. Oromotor coordination. The important components for feeding, of course, all of these have to work in a coordinated and a timely manner. So it is said that when you are putting liquid into your mouth, it has to be swallowed within 0 to 1 seconds. When you put semi-solid food in your mouth, it has to be swallowed within 0 to 2 seconds. And when you're putting solids in your mouth, it has to be swallowed between 0 to 12 seconds. So when you are putting different types of consistencies in your mouth, there are different types of coordination patterns that are involved from your teeth, lip, jaw, all of these oromotor structures in order to swallow that food. If even one of the structures amongst these goes for a toss, then there is a chance that your nutrition and feeding can be affected. Now, orosensory component. This is my favorite part. So when you're looking at food, you are not just looking at a food to be eaten to gain energy and gain nutrition. You're also looking at food from different sensory components. That is touch, smell, awareness of the food, system of movement, how you're sitting, how you're taking the food. Either you're taking standing food, like even in adults, if you're standing and eating food in a buffet, or you're sitting and eating food. Some people don't enjoy standing and eating food. They want to sit and eat their food. Visual system, how pleasing is the food to me? How is the food presented to me? Is the food presented in a haphazard manner? Then would I like to eat it? Maybe not. If the food is presented in a very well manner, if it is garnished nicely, I may like to eat it. I may at least like to try it. Swallow and digestion and hunger feeling. Of course, I should feel hungry to eat it. If I am not hungry, I might not enjoy the food. Likewise, smell, smelling the food, taking the smell of the food. Smell is the first sensation that is ever developed in a child that hits the brain. When you are born, all of these systems, your touch system, your five sense organs, and your vestibular system, and your joint awareness, these systems are developing from the birth. They are not always developed. When you're born, they are not just developed right from the start. They are developing since you are a baby till you transition into an adult. They are continuously developing and adapting. So for a child, your olfactory system is the only system in the body that is the first system to be fully developed. When you give any sensation of smell to a child, it will hit the brain immediately. And there is a very good integration between smell and food. We all know that when we smell food, we feel a bit hungry. So everything is connected. We smell the food, we feel hungry. So that's your interoceptive system. Then we go forward and look at the food, that is a visual system. If it is visually pleasing, then I may touch the food, that is tactile. How is the food to touch? Is it good? Does it feel good to my hands? Then putting it in your mouth. So this is a complex interaction of your sensory systems while you eat. Okay, I want the first. Yeah.
Sorry.
Hello.
Go to the previous slide.
Yeah.
Yeah. Actually, this was a very nice way that you shared, and this is exactly where I guess most children and individuals with different disabilities have challenges.
Right.
In terms of the children who have tactile sensitivity, smell sensitivity.
Exactly.
So, very nicely said that it goes in a flow.
It goes in a
Right?
flow.
Are you going to be sharing with us how one could? Yeah. Thank you.
Yeah,
Thank you.
I'm covering each system, like hyposensitive and hypersensitivity neuromotor structures. So I'll be covering. Yeah. Can you share the poll now, the first poll?
Yeah. I'll have to just take it up. Rajisha?
Yeah.
Oh, yes, it's shared.
No, this is not the one.
Oh, no,
This is
not
not the
this,
one.
my dear. This is,
I'll share it. You can maybe
yeah,
stop it
you
and
can share it. You can share
yeah.
it if you are the host.
Yeah.
Rikisha, can you make Dr. Rajisha the host so she can share the poll herself?
I am the host
Ma'am,
actually.
currently you are the host now. You
I'm
just
not.
make her the host, ma'am. You are the host right now.
I'm the host. Okay, I have to. Okay, this one.
Just make it
Is
Dr.
this the
Rajisha
poll?
the host.
Just a
She's the
second.
co-host now.
I am launching it. I got this thing. I've launched it. I'll give you
Okay,
guys 30 seconds to just type in a response.
30 seconds.
Yeah. Great. Great. I'm getting good answers. 10 seconds more. And done. Sharing results. That's great. 2 to 3 years, 3 to 4 years, and 4 to 5 years. I'll get to this answer in just a bit. Stop sharing. Okay. So typical development, I said that age-wise development in a child is very important to understand where functionally the child is lagging so that we can take the interventions forward from there accordingly. Stages of feeding and swallowing in infancy. So when we talk about it, we have to look at what is the oromotor development of a child, what is the motor development of a child, and likewise what kind of food is the child introduced to. So in prenatal, so we all know that the taste sensation starts developing in a child right from when the child is in utero. So begins to develop taste sensations in utero itself. By 24 weeks of gestation, the child can actually develop a suckling reflex as well. The child starts sucking the amniotic fluid while in the mother's womb. Then the infant feeding and swallowing. Here we talk about the suck, swallow, and breath pattern in the child. We see how the child is approximating his mouth towards his or her mouth towards mother's nipple and is able to coordinate between his sucking, swallowing, and breathing. Only when the suck, swallow, and breath ratio are 1:1:1, then the child will be able to take an optimal amount of milk from the mother's breast and feed himself. Okay. Transition between feeding begins around 4 to 6 months. We all know that, and I'll be covering that in greater details right now. Begins prior to birth. Development of oromotor and orosensory structures obviously begins prior to birth, continues beyond age 3. Taste develops 7 weeks in utero. Begins to develop the sucking and suckling reflexes around 36 weeks. 24 weeks, my bad, 24 weeks, the child starts sucking amniotic fluid. Okay. Now, age-wise development. I've specifically mentioned here because this is where my role comes into picture in greater details, because I have to make sure that the child is optimally positioned, his oromotor structures are well developed, so that the nutritionist can give the right amount and right type of food to the child, and the child is well fed. This internally can help me in order to bring about the functional goals like sitting, standing, all of this. So it is always a team approach. We look at a team approach. 0 to 3 months, the child is reclined, is always sleeping, right? Suckling and sucking reflexes are present. The child is on breast milk. 4 to 6 months, towards the end of 6 months, when the child comes towards the end of 6 months, the child begins to roll over. Head holding has already been attained. So the child is introduced to pureed foods. 6 to 8 months, the child can sit upright and tongue lateralization starts in 6 to 8 months. So when we are talking about sucking, suckling reflexes in 0 to 3 months, I said the infants have only front and back tongue movements. They don't have lateralization. So lateralization starts in 6 to 8 months, and the child is introduced to mashed foods, mashed solids. 8 to 12 months, standing. The child starts pull to stand, like can pick up, can take furniture support and then stand. Controlled bite. They have controlled bite. They can start biting properly, and rotary chewing movements. That is, they can chew in all the planes. So finger foods. The child can pick up the food by himself and then put it in the mouth. And 12 to 18 months, walking starts. By the end of the 18 months, the child is expected to start walking. So when the child starts walking, that reciprocal movements in the child has come. Gross motor function has come. What is gross motor? Gross motor is big movements. What is fine motor? Fine finger movements and dexterity. That is preciseness of your fingers and stuff. So when 12 to 18 months, you expect the child's gross motor functions to be fine. Obviously, the child keeps developing until the child is 7 and 8, but 12 to 18 months is a good time you expect the child to start standing, and table foods can be introduced to the child. Since the child can sit properly on the chair, can have a table to him, he can start eating solids in a proper way. Table food, matlab apna dal, rice, chapati, bhaji, you can introduce at this age. So when does a child start feeding himself? When does the self-feeding start? That's when your fine motor is also fine. Child can start using spoon and everything by 8 to 12 months itself. They can start using spoons and they can start using fork, of course, with spills. But when does a child eat age appropriately without spills? You can expect around 3 to 4 years of age. The child can do that. The child can sit with good fine motor and good gross motor function and then feed himself. Red flags. For understanding the conditions, you have to first observe. We don't directly dive into the examination and label the child. That is one of the things why we've gathered today here. Disable the label. We do not want to label a child. So diving directly into the conditions is not what, as a therapist also we do. We look at what behaviors the child is showing. What are the child's behaviors clinically before looking into his investigations and papers. So what we do is we see the child and what kind of behaviors do we see when the child has oromotor and orosensory concerns. We look at arching, stiffening of the body while feeding. They do arch their back and they are like that and they do not accept the food. Irritability can be because of sensory concerns. I'm covering that. Lack of alertness during feeding. They are not attentive to food. They don't enjoy eating as much. Food or liquid refusal. Very selective to eating. कुछ पसंद आता है, कुछ पसंद नहीं आता है. Failure to accept different textures of food. I will like only pureed foods. I will not like mashed. I will like only mashed. I won't like solids. Longer feeding times. So I told you swallowing times कितने होते हैं with respect to liquid, liquid, mashed and semi solid and solid. So longer feeding times greater than 30 minutes is something that is a red flag, and you have to be alert that maybe the child has an issue. Coughing, gagging during meals, not liking a food, and or not having a good defense not having a good defense mechanism leads to gagging. The child may gag. This is called gagging. Coughing is a good sign, actually, in a way, if it's in the form of a defense. But regularly, continuously coughing when the food is put into the mouth is something not good, and you have to be alert. Maybe this will lead into pneumonia or aspiration. Continuous coughing is not good. As a reflex, it is fine once, but not continuous. Difficulty coordinating breathing with eating and drinking. Again, this comes into suck, swallow, breath pattern. If the child sucks, swallow, and breath as an infant only is poor, the child may not have good responses growing up. Frequent spitting up and vomiting. Recurring pneumonia, respiratory infections. Difficulty respiratory infections, because your respiratory and oral structures are very connected. Your oropharynx, nasopharynx, everything is connected. So you have to look out for repeated respiratory infections like cold and cough also. Difficulty in breastfeeding, less than normal weight gain or growth. All of these are red flags. Going forward, what are the oromotor issues? So when we talk about our perspective, we look at oromotor and orosensory. So looking at oromotor issues, postural control, here you can see the child. It's how he's dropping down his side and tilting his head on one side. His both arms are outwardly turned, and even his legs are outwardly turned. There is actually a block kept in between in order to separate his legs. And he's not able to align his head in midline. How do I feed a child not able to align the head in midline? Because neck is on one side, the head is on one side. Postural control. Here it is a therapy session. Still you can see an older child putting hand to mouth. Hand to mouth is a very good thing. It comes around 4 months of age, but it starts getting integrated. You don't expect an 8 or 12-month-old to keep hand to mouth. They have to start weaning them. We have to start weaning them off from hand to mouth. So here you can see still putting non-edible objects in the mouth, which is not okay. Muscle weakness or flaccidity, floppy muscles. The child is overweight. Muscle tightness or spasticity. Spasticity is increase in muscle tone. When your hands are very rigid, you can't move. You can move, but there is a lot of resistance from the child's end. That's called spasticity. And tightness. So when there is muscle tightness or spasticity, it can also occur in your oromotor areas and can occur in your arms, can occur in your legs, affecting the overall body picture and hence the feeding. Tightness of fascia, coordination or gradation. When your muscles are tight, your muscles are weak, you don't know the correct amount of pressure to put. You will bite or chew very hard, or you will swallow very slowly. You don't know the gradation. The correct amount of pressure to apply is very automatic in us. We develop. So nobody tells me that when I'm supposed to pick up, suppose I'm supposed to pick up this object, nobody tells me how much amount of pressure that will require. If it's a heavy object, I automatically know I have to use my two hands. If there is just one hand, lighter object, I know I have to use just one hand. So that's the automatic amount of pressure that I know I have to apply. Similarly, in the oromotor structures, if there is a hard structure in front of me, I know how much pressure to apply to bite. If there is a soft structure in front of me, I know how much pressure should I apply to bite. That gradation is lost in these children, and involuntary movements. So a lot of involuntary movements are present in these children, which again affects the overall body picture and oromotor structures. Very common is oromotor dystonia, and I'll be covering that. Oral hypersensitivity. Now, these are oromotor issues. Now we talk about the sensory issues. Like I said that there are so many sensations involved when you are looking at food. What can go wrong in these sensations? When you are talking about it, what is the wrong things that can happen? So I'll put the slides of oromotor hypersensitivity only, and I'll touch up a little bit on each part of other systems as well. Let's discuss oral or hypersensitivity first. What is hypersensitivity is whenever something touches me or I have a taste of something and I don't like it, I'll be extremely cranky, cry and throw tantrums. That's hypersensitivity. I show gagging, and I don't like it. I mean, gagging in the sense again like this, and my eyes cringe, and the behaviors are very particular. So dislikes having teeth brushed and or face washed, wouldn't like it. Gags easily when eating. Brushing is a big problem. They will be very hypersensitive. If the bristles of the brush touch their teeth, they will again cringe. Avoid certain food textures. As I said, that certain textures of food, texture, temperature, and pain are something that they are very sensitive to. They like only certain textures or certain temperatures. So when I talk about textures, they will not like hard textures or they will not like soft textures. It completely depends on child to child. Not all size fits one. So every child comes with a different picture, and you have to evaluate. You have to ask the mother a lot what is the problem, and you will get the picture correctly. Fork or spoon using only their teeth. So they only touch the teeth with the fork or spoon. They do not completely put it inside their mouth because they are very sensitive with respect to their jaws, the insides of the cheek, and the back of the tongue. When they are sensitive at the back of the tongue, they will not take the objects to the back of their tongue. They will only just put it ahead. Dislikes being touched, avoiding messy play. So they don't like their hands messy. When children need, of course, their hands are going to be messy. These children don't like their hands being messy. So this is an example of tactile hypersensitivity. They will not like hands being bad. With respect to anything, any food touches their hand, they will be like, oh no, I don't want it. And they will just leave eating it. Oral hypersensitivity. Hypersensitivity is someone who gets irritated with a lot of oral input. Hyposensitivity are children who take it, who seek this input, who want more and more of things in their mouth. So they crave intense flavors. They like all the types of textures. They like to mix textures, but it is more than normal. They like mouthing of objects. Drooling is present, excessive drooling. You can see a child here who is drooling. You can see a child here mouthing. They don't chew their food thoroughly, but they just swallow. They just swallow it. Or either they keep on chewing, keep on chewing, keep on chewing. There are two pictures here. They take large bites and stuff their mouth. It's called pocketing. You must have seen children, they love pocketing. When they are hypotonic here, they do not have a good oromotor development. They will put things inside their face, stuff it on one side of the corner, and pocket it like this. Drool
They
excessively.
take a lot of time to finish their meal.
Yeah, they take a lot of time to finish their meal. Longer feeding times. That's also one of the things. Great.
But I think, doctor, I want to highlight here, like I've seen kids in my own family who've done that, and and other parents as well, my friends' kids and all, But then, is it like? But they are all fine in adults now. So is it like they
Development.
have it? Then is it something to be concerned always or not
No,
so?
so the thing is, when we look at children, we just don't look at neurotypical and neuroatypical. Even neurotypical children, that is, our kids with complete fine development, may have certain pictures of oral hypersensitivity or oral hyposensitivity as well. Like, for example, me, I used to suck my thumb till the age of 5, and my cheeks are also hypotonic. So I have a lot of taste preferences and smell preferences, but that is not going to affect my participation level. It is always good to use oromotor kit in these children, which we will be covering in intervention. So you can give vibrations to these children, and you can use another behavioral techniques to avoid and discourage their behaviors. So their oromotor structure is fine, and as adults they won't face issues with picky eating. That's something that another very big problem is picky eaters. These children are picky eaters,
Yeah,
so we have to look at it.
doctor, could it be a little louder because I think you're really explaining very well. It's just that certain things are going a little soft, so uh,
Softer. Okay, no
if
problem, I'll
everybody.
just take care of it from now. Yeah.
Yeah, thank you, dear. Thank you.
Yeah, thank you. And then going forward, when we talk about hypersensitivity and hyposensitivity, afterwards, I also want to highlight behavioral issues in these children. So, one of the behavioral issues that can encounter is, since they are cringy, they are throwing temper tantrums, they are crying, they may be not enjoying the food as thoroughly, and we as parents tend to force it. Arey, khao, 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 khao. When we are doing this with the child gets super irritated, will not cooperate with you. So, what happens that time is, they will show different kinds of behaviors. They will not cooperate with you. They will throw things around. They will become rigid. They will say mujhe aisa hi chahiye, mujhe aisa hi chahiye. That kind of routine starts developing, which is a very common problem in kids with autism. Covering it, and we'll talk about it. They have short attention span of time, and of course they have difficulty, since they have so many issues. They cannot transition to age appropriate diet. Age appropriate diet is what I already mentioned: breast, feel, pureed foods, then mashed foods, and ultimately solid foods. So this kind of transition does not happen in them, and they are lagging behind with respect to their nutritional needs. Since they are lagging behind with respect to their nutritional needs, their physical and mental growth both are behind. So we have to take care of it, and the nutritionists and dietitians here play a big role. It is always previously, when we were kids, when we were studying, and that's just 5 years ago, I graduated 5 years ago, we did not see our colleges involving nutritionists and dietitians as a part of our program, which should have been done when we are looking at neurology. When I did my master's in neurology as well, something in children, this was something which was not covered. So right now, when we are into practice, we are understanding how big a role nutritionists and dietitians play. So this is something that is, even the behavioral issues are looked after by nutritionists and dietitians as well. We work as a team, and these things are, we are giving them a proper planned meal. Proper planned meals are something that we are giving them, along with behavioral strategies, what to do. Again, I'll be covering the behavioral strategies and intervention.
Rajisha, one parent here wishes to, he's asked a question, does it go away with age, this hyposensitivity and hypersensitivity?
So there are interventions that we do in neuroatypical children, but in neurotypical children, it can occur that when you are as a child having certain issues, growing up, those issues will remain with you. But since your otherwise development is okay, there is no need for you to even dig very deep into it. You can take feedbacks and you can work it out on your own at home level. You can take a home program from your therapist and then work it out on your own level at home. But in normal children and neurotypical children, you don't see a lot of problem growing as an adult, except that they'll be picky eaters. That will stay. Otherwise, you don't have to worry so much. In neuroatypical children, you have to follow proper interventions. It won't go away. That's
somebody with a child with autism, or other, so there will be continuous interventions that will be needed.
Continues till the adolescence. In fact, they have to continue. Yeah, there are goals that are set for these children. You have timely goals. So by this month and this age, the child should be able to eat this. By this age, the child should be able to eat this. There are timely goals which are set for them. Yeah,
more individualized, case
more
based.
individualized. Yeah, not each size, one size fits all. Absolutely not, because these kids come with, every kid comes with a different picture. So you have to obviously do a thorough assessment and then set goals accordingly. Yeah, I'll go forward. So behavior food jags. Food jags are when a child will only eat certain foods and may demand they are presented the same way. Like when I told you that they are very particular about how the food looks to them. So it should be either colorful, only one color, or should be wrapped in a paper towel only. Food should be on a stick only. Certain labels should be present on the food. This is because they have poor adaptability. Anything new that you introduce to the child, a normal child will be curious. Oh wow, something new to try. Maybe I should try, will at least go and try. But a child which has these issues, behavioral issues, sorry, has poor adaptability. The child will not be accepting new things, will like to be in his comfort zone. That's called behavioral jags. Remaining in a comfort zone again does not result in learning. We all know that we learn only after we come out of our comfort zone. So it is important to introduce this child to new types of foods. Okay. Screen time and food. I have included this here particularly because these days even the neurotypical children we see, atypical को तो हम खाना देने के time mobile दे देते हैं यार खाएगा कुछ. But when neurotypical children also, kids in my house also, I've seen that they need their iPad, they need their TV in front of them to eat. What is really happening? There are several studies which have said that when the child is looking at a TV, looking at a screen and eating, the child is not developing pathways in brain which are essential for him to understand the food and develop an experience or emotional connect with the food. It's not happening. As a result, what happens is they do not feel hungry enough when they look at food. Their satiety quotient, their satisfaction quotient goes for a toss. They don't understand the amount of food that they are consuming. They don't understand the amount of food they are consuming, and ultimately results into weight gain and childhood obesity. So we have to look at screen time. We have to limit it. We have to gradually wean the child off the screen time while eating food. How can you do this? You can introduce different things, puzzles, this and that, etc. While they are eating, you can introduce other activities, but not screen time. That's something that you have to take care of. Even the WHO has specific guidelines for children that everybody has to follow. so that the child is not overly exposed to the screen. That is goes with everything, like even your eyes get affected, your motor problems arise, likewise your nutrition also gets affected. Common conditions: cerebral palsy, syndromes, ASD, and ADHD. Cerebral palsy. So in cerebral palsy, we see, actually, I'm taking a lot of time, so I will just touch on everything. If you have any questions, please feel free to ask towards the end of the session. Growth. When we look at cerebral palsy, I'll first talk about it in a gist. I'll talk about the stable in a gist. So when a child with cerebral palsy comes to you, they're extremely rigid, spasticity, or they're hypotonic, completely flaccid. They are either very tight or very flaccid. What happens in these cases, they do not have proper trunk control, they do not have proper head control, they're falling down or their head is falling down. So what happens is their nutrition gets affected. In this case, their oropharyngeal or esophageal things gets affected. There are chances of regurgitation, that is your gastroesophageal reflux disease. When your acid reflux happens from stomach to the esophagus, there is a lot of heartburn can happen in these children, which is a possibility. Again, aspiration pneumonia in these children is a possibility, right? Dysphagia, mobility, feeding. Yes, this I'll cover. Oral, enteral medications are covered by Sushila ma'am. Oral, enteral, and parenteral. Oral.
Dr.
Oral is when the
Rajisha,
food.
Dr.
Yeah.
Rajisha, sorry for interrupting. At this point of time, can we just ask a few parents or participants, um, what are their questions that are coming up right now?
Definitely.
So
Definitely.
yeah,
Definitely.
just to so participants, you may unmute yourself, or put it in the chat box. What are the questions that are coming to your mind? Uh, Dr. Rajisha has already shared with us certain challenges that happen, food being such an important thing, and this entire system, she's covered it so beautifully and in a very systematic way. So, are there any questions that at this point of time, uh, or you just want to keep listening only to Dr. Rajisha and you don't want to speak?
I can cover questions personally also. I mean, I'm open
Yeah,
to it.
like, it'll just allow participants to
Yeah.
kind of
A
interact.
few questions. I think there
Yeah.
is one question here that by Shantanam, if
No,
the
no,
child
no.
is
That
not able
question
to
is
attend
related to
preschool.
education. I have already responded to that.
Responded to it.
So
Okay,
it's
okay. And now there is
how
a
mood and food. Yeah.
mood and food goes together. So
Absolutely.
So how
I
do,
think
how they
we
want to
can
know how
talk
does
about
mood and food go
nutrition.
together?
Archana,
Sorry.
yeah, can we talk of food and mood? And right now, Dr. Rajisha is mainly covering from the physiotherapist point of
Point
view,
of view.
that how the oromotor issues and orosensory issues and the behavior issues, and she communicates to the nutritionist for
Right.
her to understand what plans to do.
Great.
Yeah.
So Mr.
So,
Pravesh, you need to wait for this question to be
so
responded
food
by
and
Ms.
mood we will
Sushila.
cover. I'm also making
Yeah,
a
Ms.
note of
Sushila
it.
is going to be covering that for you.
Yeah.
So any other question related to the system? So Dr. Rajisha here is helping us understand the entire process, the entire system, how it normally functions, and if there is any abnormality or any other challenges, how does this get affected? Which
If there is
part
a
of it gets?
parent here and the parent would like to speak to me about
If there
how
are
to
any
bring about a
parents,
change,
yeah,
yeah, or a
any
therapist
parents
who
who
would
want
like
to
to
share an
discuss a case,
experience.
that's also okay.
Hello.
Yes.
Hello.
Yes.
Hi, ma'am. This is Gemini. I'm a mother to a special child who will be 6 years old next month in April.
Could you pin her, please?
He's actually hello.
Yeah.
One minute, 1 minute. We just want to get you in the picture.
Yeah, because I'll be able
What
to
is your
assess
name?
it better.
Ma'am, my name is Gemini.
Gemini.
Okay.
Yeah, I'm a mother to a 6-year-old child and he's falling under GDD, Global Developmental Delay.
Okay.
It looks like he's a hypotonic child, so he has started chewing recently. But whenever he's swallowing the things, usually when we eat, our head is straight, right? But when he swallows the things, he is tucking his chin to his chest. It's
Okay.
very weird, and
Okay.
his speech is highly affected. He's still on babbling stage at the age of 6.
Right. So there are certain intervention strategies that you have to follow in these children. We are covering in greater depths later on also if you stay with us. Nonetheless, I'm going to touch on it right now. Since the child has global developmental delay, definitely I presume that the child is hypotonic. That is the tone.
Dr. Rajisha, a little louder. Sorry.
Sorry. One
Yeah,
second.
sorry.
Can you hear me now?
Yes, it's much better. Thank you.
So the child's oromotor structures are definitely hypotonic. That the teeth are not as tight as we expect it to be. The chew will not be as strong as it should be. So there are a lot of oromotor kits that we use in these children, which come with chewy tubes. They come with knuck brushes. So oromotor stimulation is important in these children. We stimulate the sides of the cheek, the upper part of the cheek. What I would suggest is for this children is that for this child especially particularly is if he's continuously touching his head here, this airplane pillows that come, you can introduce as a fun way to the child and make sure that the airplane pillow is around his neck. The pillows that we use as travel pillows when we are in a flight, that kind of pillows provide them a proprioceptive input, that is a tactile kind of input, a pressure kind of input between their chin and upper chest, which will help the child to keep the neck erect. Another advantage of it is it doesn't close in the front. It is not going to choke or anything. It is open in the front, which is good. So you can do something like that. Secondly,
Okay.
you stroke it here. You can massage his neck. If you massage his neck, it will facilitate his swallowing. That is something you can do.
Okay.
Third thing you can do is you can include thick liquids with thin straws. Why thick liquids with thin straws? Because the child will have to suck in with a lot of pressure. When you are making, so the food has to be visually pleasing. That goes without saying, because he's not going to enjoy the food if the food is not visually pleasing. So please put an effort to make the food visually pleasing and good to look at. So the child goes forward and will do it. Will take in the food. So if you put thicker liquids and thinner straws, the child will suck with great amount of pressure, will improve his tone here, which will also help in his swallowing. So that's something you can do, because thinner straws and thicker liquids means you have to put in a lot of pressure to suck. So there are 100 intervention strategies, but particularly to what you've said, introduce a pillow and start with putting these kind of things like thicker liquids and thinner straws and oromotor stimulation for the child, and sit with the child while you are eating food. Avoid the other distractions. Concentrate on the child. Make it a fun thing. Make your meal time a fun, and he'll be able to respond better to it. Yeah.
Okay, ma'am. And is it advisable to use a vibration brush for hypotonic child because his tone is very important? If we're using
Of course.
vibration brush, whether his tone will be much lower or it is good to use it to tight his skin. What?
So usually, what we
Because some
suggest our parents
physiotherapists,
is, yeah.
uh,
What we usually suggest
some
our parents.
physiotherapists are
You're saying
Ma'am, some
something.
physiotherapists are saying, don't use vibration brush because for a hypotonic child, if you use vibration brush, his tone will be much lower, and we want his tone to be a better. So, is it a myth or is it true?
I respect their opinion, but what we do with our children is we do give them vibratory brushes. And what we suggest is before the meal time, a little bit of vibration is not a bad thing to do. When you give vibration, you are stimulating a lot of tactile and prop receptors. Lot of tactile मतलब आपके टच के जो receptors होते हैं वो बहुत stimulate होते हैं inside your mouth, especially the sides of your cheek and the palate and the tongue. Three things that you have to look at, actually four, but in his case three things. That is your cheeks, your palate, hard palate and soft palate behind, and tongue. Okay, you have to give vibrations in all of these places before the meal, and it's absolutely okay. There is a science that goes behind it. It will stimulate your tactile receptors. In hypotonic children, their somatosensory system, that is their tactile system and the system of pressure, is less developed, is hyposensitive. We want to make it strong. So stimulating this with vibratory brush is not a bad idea, and especially before he sits for a meal. So you can spend say 3 to 4 minutes in doing that vibrations before every meal. It will help. You can introduce even tastes on top of that vibratory brush and include it, which also solves our adaptability and picky eating issue. I hope I'm getting through to you.
Or
Yeah.
yeah, absolutely, ma'am. Thank you very
Yeah.
much.
Not at all. Anytime.
There is one parent who wishes to ask a question. Mr. Brian, could you unmute yourself and speak?
Hello.
Yeah. Hi, Mr.
Yeah,
Brian.
good morning to all. In fact, just a small query. My daughter is 13 years old,
Hmm.
under the autism spectrum. Now she
Hmm.
has got a habit of, gobbling things, like, gobbling food, I mean to say, and not chewing them, like, certain foods what she say doesn't like or something like that.
Hmm.
We have gone through all these oromotor exercises with the rotations, vibrations, like and the rotations along the cheeks or the palates whatsoever. Also introduce a lot of food, as in like say like carrots or cucumbers. That would give a little of uh,
Hard pressure.
exercise kind of thing to the
Yeah,
jaws.
yeah,
Yeah,
yeah. Of
some
course.
pressure and all for the jaws.
Yeah.
So, having said that, see that everything is perfect in the diet. In terms of it's a wholesome diet, she eats a lot of.
He's broken. I can't hear him. I'm not able
What
to hear.
times do you find these issues?
I'm sorry, Mr. Brian. I
Yeah,
missed
at
the
certain
second part.
times. Sorry, at certain times only, like she tends to swallow
Okay.
the food, like rather than chewing it. And if we
Rather than
keep on
chewing.
telling her, like to
Hmm.
keep chewing,
Hmm.
she will just
Okay.
show us the action of chewing, but we know that she's not chewing.
Okay. If Sushila ma'am
Yeah.
doesn't mind, I want to show him our one intervention slide. Can I go ahead?
Sure.
1 minute. I am not able to. Just a second.
Oh, दिखावा.
Just a second. Stopping my share. I'm screen sharing again. Okay, I'm not able to show you the slide, but if you stay till the end of the session, I'll be able to show it to you. The thing is, the problem with the child, I see the issue that right now you're facing is that the child has a behavioral issue. The child is able to chew some food sometimes, but is not able to chew other times, means the child doesn't really have a chewing problem as such. There might be certain concerns with your oromotor and orosensory, but behavioral issue is a thing that you need to handle. What you can do, since a child falls under a spectrum, you can make a visual schedule of chewing. So what you can do is, whenever she bites the food, there are these visual schedules that come which show a picture: bite, bite, bite. So you can put chew, chew, chew. So you can show that visual schedule to the child. When the child is sitting for food, you have to chew. If you chew it once, I'll stick this sticker. If you chew it twice, I'll stick the second sticker. Where whenever she chews and whenever she bites, she gets that sticker. So that's kind of a reward for the child. You have to work on a reward system with this child. If you say that the child को मैं इतना instructions दे रही हूँ but वो सुन नहीं रही है, so you have to work with a visual schedule. A child with ASD or falling in the spectrum are visual learners. Since they have auditory issue and speech issue, they are visual learners. They learn a lot with their visual system. So when you show them a picture, bite, 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 or whenever she eats or chews well and you give her a star, she will tend to replicate that behavior. She will tend to replicate that behavior. I hope I'm
Rajisha,
clear.
Mr. Brian says that this is being already done.
No, he didn't mention about behavior.
He's written, 1 minute.
Yeah.
Visual schedules are already used with rewards.
Visual schedules are used with rewards and even they are not working, you mean to say? Okay. So another suggestion I would give is, since she is an adolescent, it is a bit difficult to change behavior, or change behavior in the sense to change the patterns in these children. The learning happens slow. With the age, the learning does subside. What you can find out is, now comes the role of a nutritionist. A nutritionist can guide you with the right amount of calorie intake that she has to take in different ways. If she is not performing in this kind of way, she has to take the nutrition in this kind of way. What you have to ultimately make sure is that she is getting her required calorie requirement for the growth, for her mind and body growth. So then if she is not following all of the strategies that a PT and OT are using, if that's your basic complaint, the role is of a nutritionist to give a correct calorie intake so that her nutritional feeding goals are met. Am I getting through? Hello?
Yes, ma'am. In
Can you
fact,
take another bite?
nutrition.
I'm not understanding if I got through.
Hello.
Yeah, did I
Yeah.
get
In
through?
fact, nutrition is not an issue at all, because as I had
Right.
mentioned earlier, the diet is pretty balanced, okay, with
Okay.
no, like, everything is of nutrition itself. And since both the kids are athletes, so we
Hmm.
don't have any issue on the food intake whatsoever. It is as per
Hmm.
what you said, no, we have an issue with the behavior, because see what happens mostly, if these behaviors are not controlled, it can often lead to constipation if
Of course.
you don't chew your food. That
Of
was
course.
only issue, not about nutrition.
Yeah, so that's something that you can look at, behavioral schedules that can be formed, and chewy tubes before the child is sitting for the food. So it is very important before the child is sitting for the food, the sensory stimulation is given to the child. You can also do vibratory brush with the child. Since the child is an adolescent, she can do it for herself, and she can also use chewy tubes by herself before the food, before the start of the food, and not as an isolated session. Okay. I am not able to share my screen the way I should be. Just a second.
ढेर सारा नमक है
Okay, anyway, I'll just show you these videos of a child who's child with cerebral palsy.
वो हमके ना दिन में 4 बार याद दिलाएंगे
Just have a look.
ये क्या खाने में नाटक करती है ऐसे रजिशा मुझे पूछ रही थी जनरली रुकना मैं खिला रही हूँ ना तुम खुद से खाऊंगी ओ दिखावा परेठा हो क्या जनरली पसंद ही नहीं
You can see how the child is folding her legs and bending and sitting. She's a case of spastic diplegic CP, that is, both her legs are always crossed. She doesn't sit on a chair that often, she dislikes it. And self eating, she can only eat finger food, or you can use spoons and forks by herself. She's an 8-year-old kid. Yet she is not able to, break the roti and eat by herself. That is, a fine motor function is sort of affected. She is being fed a good, wholesome meal, but this is just one time that she's using it, eating the food. She has a lot of picky eating behaviors and a lot of temper tantrums with respect to normal food. She loves junk food, so preference of food is also present.
ढेर सारा नमक है हाँ
एकदम टेस्टी है
टेस्टी लेकिन
अरे भाई
थोड़ा मैडम कटम
Slurred speech, if you say you can't understand what she's saying, that's a neuromotor issue and a speech issue again. Okay, and she's able to use the spoon well, but she's not able to tear the roti by herself. That fine motor function has not come. This has not come, but this is okay. So age wise development, she is behind, affecting her function in feeding again.
ढेर सारा नमक है
Down syndrome, we all know there are a lot of oromotor and orosensory issues. Down syndrome also comes with a lot of comorbidities like hormonal imbalances or heart defects, etc. These children have a lot of raspberries. They do this a lot, or they have grinding of teeth a lot, and they are again hypotonic here. So what can happen is heart defects, low birth weight, prematurity, low muscle tone, and difficulties with positioning and sucking. Again, uncoordinated sucking, swallowing, and breathing, eventually leading to either weight gain or weight loss. So since they have delayed milestones, if their nutrition and feeding requirements are not met, their milestones will not be achieved. So again, you have to work in conjunction with a nutritionist. Prader-Willi syndrome, very important, because one of the key factors of Prader-Willi syndrome is obesity. Why do these children develop obesity? Because they have a lot of increased urge to eat, keep on eating. This is called hyperphagia, increased appetite. This starts developing from 2 to 3 years of age. They become very irritated if you don't give them enough food. They are hypomorphic, they are hypotonics and with dysmorphic features. So you can see here how his lip is. The upper lip is very thin and the lower lip is downwardly turned. It's not maintained as it should upright. So which is obviously clearly relevant that he will have issues in feeding. Difficulty of vomiting. Since they have difficulty in vomiting, they keep on building weight. They cannot remove it out what is not desired. Respiratory problems and speech issues, behavioral and cognitive issues. So all of these affect their development. ASD, ADHD, and SPD. Yeah, the main thing that everybody is talking about today. Hypotonia may be present. Child with ADHD has difficulty paying attention and hyperactivity. What can happen is either he can be very slim or it can be obese. These children tend to eat a lot of food. Sugar cravings are a lot. So he may put on weight. It is not necessary that all children with ADHD will keep moving. Hyperactivity can be in terms of sitting also, keeping on moving like this. They may not be having gross motor hyperactivity like bhagta rehta hai. If he would have been like a bull in a china shop, that is, he keeps running again and again, he might be thin and might be expecting his eating requirements. But when a child goes obese, he's craving a lot of sugar and a lot of junk food, keeps on putting on weight. Children under the ASD spectrum have social language and behavioral issues, severe selectivity and stereotypy. So you also see in these children coming with severe autism that they will keep bobbing their head or like this. That's their stereotypical pattern. That obviously interferes with feeding, because if it comes into picture when you're feeding the child, again the child will spend a lot of time, lot of energy expenditure in eating and not meeting his nutritional requirements. And definite sensory issues, which I've already covered. Yeah. So these are the kind of things we look at in a children with autism: concentration on detail, sensory defensiveness, intolerance, social skill deficit, feeding selectivity, sensory difficulties, avoidance of novel situations, that is new situations, adaptability is poor, routine is rigid, and impulsivity. Just one video I'll show you and then we'll move to Sushila ma'am.
Ben, can you take another bite and show us how you learned to chew with your mouth closed?
So much effort to chew the food, so much effort to keep the mouth closed. You can observe it here.
Oh.
Yeah, so much effort to chew. And here you can see how she's gagging.
It looks like you're enjoying yourself. Oh, yeah, that looks like you're enjoying. Okay.
So that's about gagging and chewing.
Ben, can you take another bite?
Effort in chewing. So it's not necessary always the child's chewing should be easier. It shouldn't be too hard on the jaws. It shouldn't be like, it should be easier how we do it. What's next? When all of these children you have seen and you have evaluated them, what is the next step? You know there is a feeding and swallowing problem that is there in a child. You have observed it. You have to refer to a multidisciplinary team. Multidisciplinary team includes of your neurodevelopmental pediatrician, your speech language therapist. I think this is self-explanatory. If you want an input on any of these, I'll be able to speak about it. Pediatric nutrition, physiotherapist, occupational therapist, social worker. Why is social worker important? This can be a bit tricky. So not all our children come from good socioeconomic backgrounds. They also come from low income background. So for these children to meet their nutritional requirements, the parents must not be having as many resources. What you can do is you can refer these children to social workers and they can make a nutrition package for the child in conjunction with a nutritionist and a PTOT. So this is possible. Social worker comes into the picture here. It is important to include them in your team as well. Family. Of course, family meal times are the best times. Behavioral psychologists, since behavior is involved and what kind of behaviors are there in the children, if you report it to a psychologist, the psychologist can tell you even greater strategies on how to tackle them. Rather than a PTOT, we would require a ASD case with lot of behavioral issues to go to a behavioral psychologist. That will also work out. And I think Mr. Brian can also look into it. Pediatric gastroenterologists, because they do a lot of studies like barium swallow and endoscopic test in which you can identify if there are anatomical problems in the oromotor structures. Okay. With this in mind, and I've spoken a lot about how nutrition is important, and today's topic is majorly nutrition, even though I took up a lot of time. I will hand over to Sushila ma'am to take us through the further proceedings. Thank you so much.
Thanks, Rajisha. Since they have been sitting for more than 1 hour, as you said.
I'm so sorry.
No. Your coconut exercise I wanted you to do. That's what I'm trying to tell you.
Oh, yes. Okay.
Yeah.
I want everybody to sit, but please switch on your videos because you've
Everybody to switch on video for only a minute. Rajisha is going to make you do?
I'm going to make you do an awakening exercise since I am a PT and into Pilates. I think it is very important for everybody to be alert because I've spoken for so long and now you have a very big topic coming up, even bigger than mine. So we want to do as much as we can. So I want all of you all to sit. Now, if you can stand up, you can stand up. If you want to sit, you can sit. It's up to you. Since my video only allows me to sit, I will do that. And this exercise is called coconut. So we are going to do it. I am going to do it once and second time you all will do it with me. What is coconut? C, C, O, C, N, U, T. That's coconut. Okay, I'm making alphabets with my hand. I want everybody to do it with me. It will be good fun for you. Come on. C, O. Great. Good job, guys.
C, O.
One hand up, one hand down. N,
U,
U, and T.
Once
Great.
more.
Once more. All right. C. Do it on the other side now. Do it on the other
Let's
side.
do the other side. Yes. C,
O. Come on. Stretch your muscles.
C,
C.
O,
O. N.
N,
U.
and
T.
T.
Great.
Okay.
Good job, guys. Clap for yourselves.
Chalo.
All right. Handing over to Sushila, ma'am. Thanks for your time.
Okay. Thank you. Thank you. Okay. Someone is introducing, or I'll start. Archana.
Yes, ma'am. We have a small introduction for you.
Hi, and thank you so much, Rajisha, for the amazing, literally walkthrough into the whole. Sometimes we so-called normal human beings who eat normally don't know that there are so many things that are part of our system, which is just a simple thing that we think it's eating. Yeah, मतलब हम लोग को लग रहा है बस हाथ है अपने आप से मुंह में जाता है and then it just goes in and we're about it. But I'm sure it's an eye awakening even for me because I'm just a special educator. Like I work on the remedial part, so it is even eye opening for me to know that there are so many things, so many aspects that one has to go through in terms of ensuring that one child is able to eat safely, eat well, with all those little things that you have shared. And thank you so much. It was very, very nice. In fact, I'm sure
that
you are probably one of the youngest physical therapists in terms of nutrition, oral nutrition I have met.
I have blessed by all my team members, including Sushila ma'am, who's been a great mentor to me. Even during last first week, she's been connecting with me, and we've been trying to give as much as we could. And I don't feel that 2 hours are enough for me to talk about it.
Not at all. Not at all.
I'm glad you guys enjoyed. Thank
you.
You
We'll come up with bigger programs with all of you.
Thank you so much.
Thank you. So let's have the campaign introduce Sushila ma'am. So can we put Sushila ma'am and the students on spotlight, please?
Good morning, one and all present here. I'll be introducing our second guest for the day, Miss Sushila Sharangdar. She has done her graduation in home science in food and nutrition. Ma'am has done a double post graduation, the first in nutrition and dietetics in 1981, followed by in hospital administration in 1995. She did her diploma in yogic education, natural living, and naturopathy, and a certificate course in nutrition, packaging, and food safety from AIMS, and ketogenic diet from AIKD. She is a diabetes educator and has done certified gene practitioner course from Canada in 2020. She learned yoga for special children from Mr. Praful Urja. Ma'am has a 40 years experience in hospitals like Hinduja, Wockhardt, Nanavati, and many more, clinical and corporate wellness and academics. She has also been a member of IDA, NSI, AFSTI, IAPEN, AIARO, AED, presently associated with ICICI Bank and group companies HPCL, BPCL, IOCL, Masdao, Push Institute, and has also been associated with Sneha Pediatric Physiotherapy Center since more than a decade. She is also associated with Shaping India Mulund and Healing Hands Physiotherapy Center Chembur recently. She conducts workshops for professionals, parents, nutrition students in New Delhi, Mumbai, and Kolkata. She has also designed an online course in nutrition for children with special healthcare needs 4 years back. Ma'am, we are very lucky to have you and we are looking forward to gain
Thank
a
you.
lot of
Thank, thank you.
Thank you so much.
Thank
Please
you.
give host rights to Sushila ma'am.
Thank you. Okay, I'll start. I'll start. Archana, you're on mute.
Yes. You may start, please.
Okay.
And participants, please let us have more participation from you all. This is for you. Ma'am knows her subject, and you know she doesn't have to listen to her own conversation throughout the session. Kindly, ask the relevant questions. Ask, pause and inquire, because that's how we will all grow together, right? None of us are masters here, so ma'am is here to guide us. Thank you, ma'am.
Thank you. Thank you. Thank you, friends. So probably as already told by Dr. Rajisha and Archana, that we were probably looking at as, oh God, it's a nutrition and we are learning all about the physiotherapy. But I just want to give you a little background. So way back in 2007-8, when I started work with special children, I mean, we would just go by what we have learned in planning the diet. And then when you do a follow-up after a month, after 2 months, it's like, खाती नहीं है, बच्चा खाता नहीं है, आपने बोला लेकिन खाता नहीं है. And then I would discuss very vaguely, me and physiotherapist, and we would say that, okay, let's work on the oromotor issues, but not to the depth what Dr. Rajisha covered in last 1 hour. So over a period of time, we formed a team approach as it is supposed to be, and we could see the results. So whenever we conduct a workshop, because it's a mixed audience, it's not just a physiotherapist and occupational therapist who would know all about the oromotor issues. There are parents, there are students. So we always prefer in the first few minutes cover the oromotor aspect of it, what is the role of each of the oromotor organ, and then the functions and the issues related to each condition. Once we know this, I know as Archana ma'am said that, oh my God, there's a whole list of things that the nutritionist has to take care. And if you're going to take care of all this, you'll say, I can see only one kid in a day. No, friends, it's not like that. So now this session will cover all about the nutritional requirements and how do we do the assessment. All right. Then we go on to the intervention. Fine. So what we are going to cover is better understanding of the complexity of nutrition in children with special needs. Talk about how their needs differ and influencing factors. Some tips on how to improve their diet and discuss some of the current diets in special needs. I don't know if you saw my first slide. So this is what many parents do these days, and they follow multiple diets at one go, so then we don't know which diet is helping them more. All right, let's start. So if we start with this, there's only one pretty child in the world and every mother has it. So every mother does best I'll give you a very classic example. So there is a 1-year-old kid girl referred last month, almost a month now. She completed on 4th February her first year and referred by a physiotherapist. In the first 6 months, as we know, the weight doubles. In the second 6 months, that the child has not gained even 100 grams. So the parents are concerned. They spoke to the pediatrician got in touch with the physiotherapist, and she got in touch with me. Now the expectation within a week was, weight is 6.7, ma'am, kuch bhi nahi bada. Not possible. So giving them realistic goal, you need to do a detailed assessment. But after doing detailed assessment, we need to plan the diet on the basis of nutrition requirement. Hence, we are covering first the nutrition requirement. We all have learned by now. I may go fast on certain slides so we can, cover more on the practical assessment and the intervention. So as Dr. Rajisha has already said, there is more than just about eating food. Chewing and swallowing difficulties with different textures, flavors, colors. There are behavior issues and use of food for behavior modification. So all this is causing a lot of concerns for us. The concerns become what? All interrelated. Altered nutritional needs, physical problems, and behavior issues. All go hand in hand. Even a few examples or the queries which we came up a few minutes prior, we'll try and discuss in our intervention. Okay, how they can be worked upon. And to my good luck, what happened about this 1-year-old kid whose mother is being too anxious. Now, last week when we were doing follow-up, this kid has to take about 1,000 calories. But when I calculate, it's just 525 calories. How do you expect this kid to gain weight? I told Mama, and now she's getting more and more empowered. Madam, आप मुझे पूरे दिन का जो items दिया है ना, उसका calories दे दो. So now she and me, we are working more together on daily basis to increase the calories. But to my good luck, to convince her, day before yesterday, I got a message from a doctor whose kid was 1 year in November last year and had got a reference because she was 7.1 and she had to be 8 kgs to undergo ASD surgery. And in 4-5 months, this kid has gained 1 kg. So she messaged me day before that now the kid's weight is 8.14 and she is all set for surgery next week. So the same chat, I sent it to her. So I said, you have to be patient. So probably, of course, we know each kid is different, but there are certain things to convince the parent, we may have to kind of, bring to their notice that this will happen. Dr. Rajisha spoke about growth concern. A little more I'll talk about it is, what does growth say? It doesn't say that you are in good health, but majorly what we are talking about here is the child normal weight, underweight, overweight. We all know that with these growth curves, I'm not going into the detail. We have too many things to talk. So certain theoretical aspect, we can look at it. If you all need any information, you can ask Archana ma'am, or even when you're saying now, I'm making a note, I've kept the diary ready. I can email it to Archana and then she can forward it to all of you. So there are specialty growth charts. We do refer that. So growth will tell us whether the kid is overweight, underweight. Now, why will happen under or overweight? There will be alteration in growth and activity. There can be poor absorption. There can be poor metabolism. There can be poor excretion. There are drug and nutrient interaction, and there are feeding problems. I think I need not tell why a person is underweight, why a kid can be overweight, but I definitely want to emphasize on this slide. There was a study done in 2010 on ages of 12 to 18 with physical, intellectual, and behavioral concerns. So if you see here, ASD kids, almost 67.1% are overweight. Downs 86.2 are overweight. CP 18.8. Spina bifida 83.1. Intellectual disability 39.6. All right. So overweight obesity is one concern which we need to definitely look at. I think we can skip this. A quick run through, because some are nutrition students, some are parents, some are therapists. As Dr. Rajisha said, we are not really taught nutrition. So what we need to understand is, and Mr. Brian sir was saying that yes, nutrition is not an issue, but for everybody's knowledge, that we plan calories, energy. We will talk about it in intervention, but it has to be in the right proportion from carbohydrate, protein, and fats. All right. Giving you I may give you little example here. So recently we had a kid, 4.5-year-old, ASD detected at the age of 1.5 year, has come to stay at her grandparents' place. Now, when I take the diet history, I would love to show you all those histories, but we don't have time. But that's why I just want to share. Uh, the breakfast is about 50 grams of chakli and 75 grams of chips, because she likes crunchy stuff. Evening, again, similar thing as a snack. So, and because AST means no gluten, so we are not giving chapati, but we are giving rice lunch and rice dinner. Day is over. So are we getting right kind of energy from macronutrients, carbohydrate, protein, and fats? Definitely not. All right. Then there has to be sufficient vitamin, minerals, fiber, and water. I'm not discussing in detail, but key pointers, diet has to be balanced, keeping in mind all the other aspects of physiotherapy part, what we learned, and then planning the diet. All right. Medication, definitely. Most of these kids are on some medication or the other. Just a few examples we have given here is Ritalin decreases your appetite, Risperdal, which is SSRI drug, which can increase your appetite. Seizure medicines can affect your calcium, vitamin D, folate, and so on and so forth. So we need to have knowledge of drug nutrient interaction, which we all learn at even our undergraduate level. Okay? Let's discuss quickly on the conditions and their nutritional management. CP, because of the concerns that we have, as Dr. Rajisha showed you, they're either physiological issues or their sensory issues. Growth is affected. They can be overweight and underweight, hypotonic or hypertonic, tonic, reflux, diarrhea or constipation. And in feeding, is it oral feeding or we are giving tube feeding? Now, why I again repeated this slide is each case is individual. So I know, I mean, when I started it, as I told you in 2007-8, I remember seeing a CP, I would call it kid. He's 28-year-old and he drives, because from the time he was detected, he can drive from where to where. And he comes for his therapy on his own. So depends on how much the kid has recovered and what is the grade of CP. According to that, we definitely look at the requirements. So if we look at requirements of calories, it is as per BMR, basal metabolic rate, as we always count. Protein will be as per actual body weight, and hydration depends again, is the kid having constipation? All right. So typically, if we look at fluid intake, it will be the first 10 kgs, as we always calculate, 100 ml per kg, and thereafter 1000 ml. So 10 to 20 kg, 1000 ml plus 50 ml per kg. For each kg, about 10 kgs. All right. Then again, as per height, also there are calorie calculation. Not to confuse you too much in such a short seminar, but there are. This was just to tell you that yes, there are. So see, without motor dysfunction, it will be 14.7 calories per centimeter. And with motor dysfunction, obviously, because their movement will be less, so 13.9. And absolutely non-ambulatory, then it will be 11.9. Okay. So what is the nutrient explanation as far as CP kids are concerned? Malnutrition, They may not be able to take enough calories. Or on the other side can be obesity, vitamin D deficiency because of poor exposure to sunlight, or they may also have GERD issues. So a detailed assessment, which we will be discussing later, will tell us. So this is broadly how we would look at the nutrition aspect of CP kids. ADHD. Every parent says my child is hyperactive. Which parent says no, 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 my child is not. Am I right, Archana?
Absolutely. Absolutely.
Okay. So I don't know. Can anybody put it in the chat box? What do you think the reason could be? The parents feel their child is hyperactive. Quickly, quickly. Oh, I'm not able to see the
Could
chat
you
because
unmute also and speak, all of you?
yeah, quickly. Couple of people, and then we'll go ahead.
My reason would be that they don't let me do what I want to do, so they are hyperactive.
No, no, no. Okay. No, no. So why are they hyperactive? That's what I'm saying.
Because we are not attending the child, somebody is saying.
They are not attending. Partly one reason could be that. Secondly, but that doesn't mean they're ADHD. Huh? I'm just in general talking about how, like, oh my God, my kid doesn't sit even for a minute. He is all the time active, hyperactive. Can somebody say something, or else we'll proceed? Is there anything on chat? You are on mute, Archana, if you're speaking.
They're saying not much of social involvement. Friends are not there, so they want something that they wish to do. Maybe junk food and soft drinks are creating that.
Absolutely. Absolutely right, all of you. All of you. We'll be talking more about it.
Given by elders.
Yes. Also, I partly we are giving them, especially as we discussed in the first part of the session, they are with their gadgets. They are so much of I. So I designed about 5 years back for corporates, since I'm into corporates also, a program which at that time people told me to patent it, I syndrome. So it is common in adults, and also it is becoming more and more in so iPad, iPod, iPhone. So it's becoming eye thumb, eye neck, everything. So a lovely program I had designed on eye syndrome. Of course, it's not as per.
And it's so valid now, ma'am, with the pandemic, everybody sitting at home. It's only I with so many people in the house also.
Absolutely, absolutely. So what are the common challenges? I'm not going fast, right?
No, ma'am. No, ma'am. No, ma'am.
All right. No?
Ma'am, one more thing I wanted to ask is, this ADHD, ADD, sometimes they get diagnosed like, I know a few adults who got diagnosed much later.
Yes.
If you could throw some light on that as well, how we could help.
Sure, we'll do that. We'll do that. So common challenges ADHD kids will have is sensory issues. We all know that. Constipation could be common, and because they are too much of the junk and the sugar, the sweets kind of stuff, that can increase the hyperactivity. How will nutrition help them? Many ADHD sufferers insist that eliminating certain foods from their diet do lead to significant improvement in systems. So a lot of elimination diets are being followed for ASD and ADHD typically, not so much with Downs and cerebral palsy and DMD and Prader-Willi, whatever other cases we will discuss. All right. However, removing sugar from diet does appear to help some children, particularly younger children. The American Academy of Child and Adolescent Psychiatry believes that the removal of certain dyes and other substances can be beneficial in some children. This is especially effective when artificial coloring and flavorings are removed from the diet altogether. Friends, even if smallest of the change that you suggest to whether adults or kids, immediate the brand comes in the mind of the person, whether adult or the parent, for the kid. Can I buy this? Why, when we can make at home? So anything packaged and bottled and canned would definitely have some amount of additives, preservatives, coloring, something or the other would have. And if these items are consumed on regular basis, it will definitely affect the kid. Now there are plenty of diets. Let us look at what we should do is, if you talk about carbohydrate, more of complex carb, not the refined. Like sugar, as we know, is refined. Complex is your whole grains, pulses. Then more of fibrous vegetables and fruits. High protein. Friends, I have noticed protein is very much lacking in people's diet, whether it's kids or the adults. Okay. And less of simple carbs. Omega 3 plays a very important role in many conditions for overall general health also. So we should try and include omega 3 food. Now, what is important is, as even the earlier queries were there I wanted to intervene and say, when we are saying that, as let's say, Mr. Brian, sir, you said that she swallows sometimes fast. Maintain a diary how often this happens. Does it happen every day, every other day? So maintaining and then relating it with her progress or regress, how is it affecting? So keeping a diet record is very, very important. Okay. And slowly, whatever foods we are adding, we should add slowly one by one. Any kind of, like, too many things don't start together. I'll show you in the intervention how we tell them to go slow. Okay. So this also we can do it in intervention. So basically in ADHD, as we said, that the more natural food and less of these colors as additives, preservatives. Similar thing applies also in autism. But autism, the minute you see one kid, any new kid, the first thing the mother is following is GFCF. So just thought, let me put a small information on that. Leaky gut syndrome, casein and gluten can cross through intestinal wall, enter into spinal fluid and act like opiates and affect CNS behavior and can result. It's not that it is, like we know so many kids. Now there is, the problem happens, you know what? The Google slide which I told you. So parents, like I know of one kid, 4-year old, come from abroad. His mother used to follow GFCF. This is many years back. I learned about the new diet on that day with the mother. I'll be very honest. Body ecology diet.
What?
And I'll tell you. And specific carbohydrate diet. So 3 diets she's following, and she has done gene therapy also. Now, what has helped out of the 4, we don't know. Now, her concern was, in GFCF, I'm not giving this. In body ecology, I'm not giving this. So, we know not giving. In SCD, I'm not giving this. I feel he's lacking in calcium, iron, and blah, blah, and blah, blah. Believe me, friends, I mean, I have calculated that kid's diet, that she makes bhakri, chotu sa bhakri he eats of 10 grams. Usme she puts 2 grams jawar, 2 grams bajra, 2 grams nachni, and like that maize ka atta and all. Because gluten free. Oh, I can't put soya because soya is not allowed in body ecology. Whatever. So why I'm giving these little examples, friends, if you plan to do more work on this, you need to be a lot more learned in this topic. All right. So we go ahead. What is GF?
One question.
Sure.
You were talking about colors, food colors and everything. One is the artificial thing that we are consuming and we are making our kids consume, all the creams and whatever. Yes, it's unfortunate. It's part of our, it's become like a part of the diet. But what about, nowadays there is so much of adulteration even in food. Like if I take haldi, if I say, okay, I'm not going to buy any artificial things, but with haldi, I'm going to, use haldi in cooking or use some, chili powder. Those come with additives and stuff like that. How do we prevent that? So, shifting to my question is shifting from whatever I'm following right now into a completely natural food diet. sometimes becomes expensive. Like even as a family, it becomes so expensive. All the natural packet foods which are coming organic are all very expensive. So how
Absolutely.
does that one make those choices? Please, if you could
Okay.
guide in.
Okay. Two things I would like to tell here. One is the expensive part. We will not buy expensive stuff. So what we will do is, almost a decade back, I have done a series of TV programs on adulteration. More than decade, maybe 12 years back, I have done. Okay. So at that time, there was not too much of home kit for you to see and test, but now FSSAI website has. So my first suggestion would be, go through that document, take a printout, keep it with you, and start slowly doing those simple tests at home. Is my food adulterated? Especially because you said from haldi, or there are many parents who feel sugar nahi dena hai, to honey I can give. So honey and oil and ghee, lot of tests, home tests are there. Okay, and then we can see. I'm not even talking about organic, because again we really don't know, like
How
how.
organic it is.
So the first step would be this, and then we see which brand is at least comparatively, like honey. Recent research was there by Research Institute. 13 brands of honey were tested, and I think almost 11 did not fit in the criteria, or 10, and just 2 or 3. So probably we could go for those kind of little research, and it will take us time. Any shift we know is going to take us time. Okay. So gluten is what we are talking about in typically wheat, rye, barley, and some amount is also there in oats. And casein is from the milk. So typically gluten and casein. I'm not going into the detail. So yes, it did show initial trials. See, we are very research-based people. So very important is to go for research. We can't just read something and get started. Okay. So yes, it had shown improvement in social interaction, language use, and comprehension, sensory. It did show, but it may not show in all kids. All right. And once again, it can be not very practical. Okay. So what we have to see is it not universally successful. And as I just told you, I'm not reading each and every line. Very difficult to stick to, especially for picky or selective eater. Imagine some kid who's eating roti and parathas, and we start giving them bhakri completely. No milk. We have come across different kind of kids. Like there's kid who's in the joint family, and the daughter-in-law is told, literally, तेरे को क्या हो गया है? बच्चे को दूध नहीं देती है. You got it? So there are various
Societal implications.
Yes. So all that also comes into the picture. Okay. Now, in autism, typically, as I told you, there are plenty of diets. I've just little summary I have put, and few diets. If at all you want more, as I told you, you can tell me, and then I can start mailing Archana ma'am whatever has to be done. So GFCF, then there is food sensitivity elimination. Slowly start removing one by one food, and you see the improvement. Then Fengold diet, then specific carbohydrate, I already told you. Then body ecology diet is anti-yeast diet, combining principles of anti-yeast, including no sugar, acid, alkaline, and fermented foods. So you have to look at the pH of the food, you have to look at the fermentation part of it, you have to look at no simple sugars, and so on and so forth. Now, if you see on an average, a few researches which are done, roughly around 50% improvement is there from all these diets. But again, it depends on every kid. Actually, all detailed diets are given. I don't think so. We have that much time. We are already at 12:30. We have assessment and intervention. So you can just go through this. Then omega-3, yes, this is something which we definitely have to give, as it can inhibit body's inflammatory response, may help reduce children's asthma, heart diseases, even rheumatoid arthritis. important in infant brain development, in ADHD. So we know omega-3 sources: fatty fish, walnuts, flaxseed, soybean, canola, and flaxseed oil. Elimination diet, helpful, various supplements. Don't start giving supplements to the kid just, okay, this is good for this particular condition. One, of course, when you see their history, the neurophysician, or depends on what the condition is, has already prescribed a certain. So your proforma, I'll show you the proforma and assessment. Is your kid taking any nutrition supplements? So on the basis of that, and what I do is certain key nutrients. You know how we learn even in our college? A particular condition. So when it's a heart disease, we do cholesterol, sodium, in addition to energy, carb, protein, fat. So like that, few key nutrients I calculate, and on the basis of that. So this mother who I told you was following 3 diets plus gene therapy. You won't believe it. Her assessment took 2.5 hours for me. Only the assessment. And I came back home, and 3 days recall, I calculated these key nutrients. I sent it to her, and I said, now these are the changes that we have to do. Because mothers, one, they are hesitant to make change. Hesitant, definitely. However convincing you can be. So we have to go very slow, as someone had written in the chat box in the earlier session, baby steps. Important is baby steps. Okay,
So
this we
that
already
actually helps, especially in in families where there are children with special needs. It helps to have a family consultation after the assessment is done.
always. So on
Because it's
this, I
very difficult to convince your older parents at home, or things like that.
so I'll share with you one incidence of online consultation during COVID. The kid was from Nasik. The grandmother, the grandfather, the mother, the father, and the elder sibling. Everybody surrounded that kid. And grandmother started saying, हम तो इसके लिए ऐसा ऐसा soup बनाते हैं, तो ये भी उसको दे सकते हैं कि blah blah, all of that. So each one was trying to, give their input. So it is very good, very good. Okay, so which diet is right for you? Unfortunately, I would say I don't know. Why? Because you have to assess the kid. Assess. You'll say, then why should I attend your session if you don't know? Okay. So as none have a high success rate, you have to work with your registered dietitian to determine all the symptoms, complete diet history, and all that. Okay. Now we go on to the Down syndrome, where already Dr. Rajisha said weight gain is a common issue, feeding and drinking issue, and due to low metabolic rate, low calorie diet. So if we have to look at the nutrition aspect, 10 to 15% energy can be lesser, especially those who are overweight. But like I have my colleague who lost her Down syndrome baby at the age of 10. He was thin. He was thin. Why? Because he had multiple heart problems. So friends, though we are talking, this is the kind of recommendation, but it will vary. Whereas I remember, like when I was small, I'm now 61 running. And when I was maybe about 10-year-old and there was a Down syndrome, at that time we didn't know. We used to only call him by name and we say that Bisham ke jaisa bachcha, like that. So we didn't even know at that time, aisa kuch hota hai, because we had never seen any kid. Now, this child was obese, not ready to go to school. He survived 50 years. He died a couple of years back at the age of 50. So it's very, I'm only telling few cases what I have seen. So you can probably relate when you are doing the consultation. All right. Then whatever their feeding issues are there, we need to take into consideration. Then excessive weight gain, as we just said already. Then if there are any kind of food allergies, we need to look at. If there is constipation, we need to look at. Plenty of fluids and fiber rich. So the Proforma has everything. All right. Then supplements. In Down syndrome, typically, there has been no really conclusive studies which say that vitamin and mineral supplements help. All right. Appetite. can be very vulnerable depending on the infection, in particular, any kind of chest, ear, nose, throat infections. So a probiotic yogurt drink will definitely help. So these guidelines, I think when we do the case, we can do it. Prader-Willi, as you can see, kid to adult. Obesity is one of the most common concern, and one of the key point is because physical activity is restricted, and physical activity is restricted due to low muscle tone, hence the calorie restricted diet. All right. And in the first year of life, because of the development issues, we may have to use adaptive bottles, nipples, all of this. Dr. Rajisha can probably cover when we do the cases. And as far as the nutrition part is concerned, maybe we'll have to use some concentrated thick formulas. Introduction of solids can be delayed, low calorie diet, 800 to 1000 calorie maybe supplement of vitamin and calcium. Okay. So probably the recommendation is a high fat, moderate carbohydrate and high protein, and definitely some amount of fiber, which will help. So as we always say, the food you eat can be either the safest and most powerful form of medicine or the slowest form of poison. Now let's go to the assessment part. If you all want to sip water for a couple of minutes, you can take a couple of minute break and get set for the practical aspect. Till now, more or less what we covered was the theory part of it. Archana ma'am, can we take a couple of minutes break or we can continue? Okay, let's continue because I can't see the chat, so I'll just go ahead. I was asking you, can we take a couple of minutes break for participants to drink water or something? Or we can continue.
You spoke like a true nutritionist.
Yeah.
I just went for mine.
Yeah. I also, in between, when I was switching off my video, I was doing that.
No, it's necessary. I think all of us forget, with the screen in front of us in any which form.
Exactly.
Yeah, thank you so much, ma'am. That was very thoughtful of you.
Or
So
a couple of minutes.
have a water break if you want.
Very important. Till then, if couple of questions we can take.
Yeah.
If anybody has any questions, put it in the chat box or unmute. So whatever we spoke on the nutrition requirement.
Best nutrition, best
Could you switch on
medicine.
your video as well, please?
Yeah.
If you don't mind. Yeah. It'll be great to see.
What was the best medicine you said?
Medicine.
Medicine.
Yeah, best.
For what?
Best medicine, the last sentence that she said, no? The best
slide?
medicine, something she said.
Food.
Earlier slide.
This slide, I think. So,
Yeah.
No. So remember, medicine can be the nutrition supplement also. So the food that you eat can give you your vitamin B6, B12 or whatever, instead of taking the supplement. You understood? Your food itself can be the safest and most powerful form of medicine. And if you're not eating properly, like I told you about this ASD kid, 50 grams of chakli and 75 grams of wafers. So what can we say? It is the slowest form of poison. Shalaka ma'am, you got it?
Poison.
Samajh aa gaya?
Yeah.
Any questions?
One more.
Yeah,
Omega-3 is the most I think in the vegetarian diet, I think.
Shalaka, you're not audible. Could you be a little louder if you don't mind, yeah?
And also video on
Yeah. Okay. A minute. Go. I think omega-3 in the veg diet, most of us don't have any food.
Why? We just said it's very easy. Omega-3, what sources we said in vegetarian?
Oh, sorry?
What are the sources we said in vegetarian? Very easy it is. Flaxseed, it's cheap, 200 rupees a kg. Walnut, and we don't have to eat in quantity like that. That's the best part, no? You understood? Yeah.
Yeah, but flax seeds, where do we generally use? Like even for
Oh my God, in many ways, many ways. Very good you're asking this question. And even soybean.
Ma'am, what is the question? Could you repeat for everybody? Because
Omega-3, vegetarians diet is less omega-3.
Right, right.
If I heard correctly, Shalaka ma'am.
Shalaka, is that what you're asking? Shalaka?
I think so. So
yeah, is that what you're asking about omega-3 in the vegetarian diet?
Yes.
Okay.
Ma'am, you can share.
Yeah. So very easy for us to incorporate, and there is a recommendation that so many how much is the recommendation for omega-3 age group wise. I can share the chart with you, and then there is a list which has how much of omega-3 is present in these food items. And important is to maintain the ratio also in general, omega-6 and omega-3. Omega-6 is majorly present in our oils. So we tend to use a lot of oil, and as a result, omega-3 goes very low. So the ratio is the mismatch. Okay.
Ma'am, there is a question on the chat which says, which are the specific foods for children?
Your voice is cracking.
Foods who have speech. Am I audible?
Audible, but break ho raha tha.
No, what are the specific foods and fruits for a child with autism who's a teenager and who probably has non-verbal and is probably on the severe side of the spectrum?
What are the foods for autism?
Food and fruits, specific fruits.
Fruit. There's nothing like that. Yeah. So again, as I said, the first and foremost important is the assessment. I'll tell you one kid, for example. From the time he was detected autism, just outside the gate, there is one restaurant and he would make paneer in a particular manner. 30 days of the month, only that paneer comes. Understood? Now, how difficult it is for me or how easy for me to make changes. So when we assess all this, the present, what is the pattern? The best diet is a balanced diet, what we said, carb, protein, fats, as natural, as home cooked, the better. Of course, we'll make it tasty and everything. Got it? Now for this particular kid, once we assess to what extent, which is the most easiest for the parent from his or her experience, yeah, I can try this first. Let's say, for example, what Shalaka ma'am asked about flaxseed. So we can grind the flaxseed, put half teaspoon in the dal, bland taste. It will not change the taste of the dal. Absolutely no. If this kid is having chapati, put half teaspoon in your chapati atta. So I'm going to cover, actually Sapna is not able to come. So I'll cover these tips also in the end. That is also a part of our program. How to make your recipes more interesting. Okay? Chalo. Let's start?
Yeah, go ahead.
Okay. So dietary assessment, very important. We will know like what we were talking just now. Where are the gaps and where are the excesses? So this autism kid of mine is taking high fat, but nutrient wise is very low and even the calorie wise is very high. What do? I can't stop her chips and chakli which she is eating twice a day, but I can say 75 grams ka 50 grams karo. This took me 6 weeks. 6 weeks it took me. So it's not an easy job, we know that. But it will become easy when we start documenting and following up. Then it becomes easy. Okay. So then we plan the intervention. So what is the role of a dietitian? Good nutrition is vital for any age, with or without special needs, to grow and develop, and for adults to maintain good health. Dietitian will plot the weight and height of the child with special needs on what needs specific growth. A quick review on, so what we will do is assessment, intervention, follow-up, and further evaluation. Kitna weight bada, or whatever the concerns were. Okay. So what we do is we ask the family to bring food to feed the child. In addition to, we tell them prior to send feeding video. If the child is eating on his own, or if the parents are feeding, caregiver, whoever is feeding. Then there is a brief interview on the basis of the proforma that we'll be sharing with you. Observation of feeding and behavior of child with parents and caregivers. So how we do is, since the therapist has a oromotor kit, she sits on the floor on the mat, and she has her oromotor kit with her food items. Whether the child is liking Monaco biscuit or the child is liking Parle-G. Whether the child is liking the crunchy chakli kind of a thing, or some soft pulpy chocolate. So all of those, and the dietitian sits with the proforma and takes history from the other parent. So simultaneously, we are doing observation of the entire understanding of the behavior and the nutrition aspect. Then there is oromotor assessment, as I just told you. So in dietitian proforma, we have anthropometry. We are all very familiar with it. I don't want to go into detail. Then biochemical, all the blood parameters and everything, clinical signs and symptoms, then the diet, and what kind of exercise. Okay.
Ma'am, I would like to interrupt if you allow.
Sure, sure. Who's
Ma'am,
there?
as I've already, this is Gemini, I've already put in a question in the chat box.
Yes.
Saying that my child is having a problem of epilepsy. So it is a special medical condition.
Yes.
Although his attacks are not very severe, he has a mild epilepsy, and he experiences this twice or thrice in a year, or maximum 4 times in a year. And he is on anti-epilepsy medicine since last 2 years. So his ammonia level is at 46, and the normal range is 0 to 47. So is it advisable to give him a proteins, because proteins are
You have asked that
increasing?
question. I wanted to ask when we do the case studies and the intervention part. I have that in mind here. So I wanted to know, that's what I wrote to you, since when the ammonia level has gone high.
Ma'am,
And
recently we had one blood test before 2 months only. So we
so we will talk in the intervention part. Okay? So this we have done the assessment. Now what you're saying is the assessment part. So in assessment, we have done the biochemical parameter, and Gemini's kid has got, how old is the kid, baby?
6 years.
6-year-old. Okay. So has high ammonia. We'll talk about it in the intervention, if that's okay. I read your query and I have it in my mind. All right.
All right, ma'am. All right. Yeah.
No worries. No worries. So we do detail assessment. I'm not going into the detail of each of these. And then feeding behavior that the physiotherapist does. Now, we have done the entire assessment. And all these are added in this proforma. If you see, initially when we prepared the proforma, it's about 12 pages. 12 pages proforma. So name, age, height, weight, because I've taken an image, I couldn't attach the proforma. So all the various points, what were there, anthropometric, biochemical and everything. And the birth history, what was the birth weight, all of that is there. Here also, then non-vegetarian, vegetarian, how often, what the kid eats. Now, important is, we will define the goal. But here the ending is, what are the 4 long-term goals of the parent? Let's understand from them. What do they feel their child should be achieving? in next 3 months, 4 months. All right. And on the basis of that, then we also, ask them what is their present intake, what time, what they eat. As you can see here, present diet pattern, a typical 24 hours recall, how much, and remarks. Remarks is what? He ate, but he vomited. He ate, but he ate little, but was choking. So any remarks, and this has to be assessed in depth by the dietitian nutritionist. All right. So that's important. So for how typically we take for diet history, 24-hour recall, food frequency questionnaire, dietary history, food diary method, and food payment method. All right. Intervention, treatment takes different shapes. So they need to have specialized training, parent education, behavior, social support, strategies, and medications. Now, Rajisha will be taking over to talk from her side what is the assessment and the intervention.
Yes.
Rajisha.
Yes. Can you just spotlight me? I'll then screen share. Okay. Good to go? Can somebody tell me if I'm good to go? Okay. So yeah, assessment by therapist, that is OTPT assessment. What do a physical therapist and occupational therapist look for in children with special needs, particularly so that we can aid the nutritionist and the dietitians to provide a proper diet suiting the motor pattern and the sensory pattern of these children. So what we look at are four major things. We look at their oromotor structure, we look at their oromotor function, we look at the structure, how is the place of the lips, how are their cheeks, how are their palates, etc. We look at their function, that is if they are coordinated in a proper manner, if they are doing the swallowing in a good time, if they are approximating their lips at the same time able to chew, how hard they are chewing, how soft they are chewing, are they applying proper gradation, applying proper pressure. That's all that we assess. And we look at orosensory, that is we look whether the children is hyposensitive or hypersensitive in his areas, which areas he is hypersensitive. We look at even the fingers, is he hypersensitive or hyposensitive in his fingers, is he avoiding certain textures, is he avoiding certain tastes, is he a picky eater. All of these things come into our orosensory assessment. Behavioral issues is one of the biggest parts because all of these children come with typical behaviors. We also have to look at their behavioral issues, for example rigidity. Are they very rigid to certain type of food or selectivity? Are they rigid about where to eat, how to eat, what time to finish their food in, who should feed them if they have rigidity in that aspect as well? Rigidity is one of the common complaints in cases with ASD is what we see. And other behavioral issues also that come into picture like adaptability, if the child is again taking food with a good novel interest, etc. So what do we see when we talk about oromotor structures? Obviously, I told you that we look at lips, palate, tongue, jaw, cheeks, and respiratory function. So why palate? What palate do we look at? What do we assess in the palate? We see if the palate is high arched palate. If your palate is high arched means the palate will be curved. Usually seen in cases with Down syndrome that their palate is very high arched. So then the tongue to reach the palate is not possible. The child will ultimately start having an open mouth posture or a protruded tongue because they seek that movement. When I'm protruding my tongue, you can all try it. When you're protruding your tongue is touching the hard palate. They need that input. They're hyposensitive in this structure. They are hypotonic and hyposensitive both. So they kind of seek that sensation and they keep on protruding their tongue. So even their tongue is hyposensitive, even their palate is hyposensitive. All this due to a high arched palate. Lips. Lips can be thinner, thicker. Lips are not approximated. Lip approximation is very important when you're closing your mouth, and in breastfeeding especially, you should be able to put both your lips towards the nipple in a proper fashion in order to suck the breast milk. So it is important that your lips should be approximated. As you grow up, your lip closure will be attained. By 18 months, even your lip is completely approximated. Lips are completely approximated. Tongue. Tongue, I told you we check the movements of the tongue, that is anterior, posterior, and lateral. If all the movements and all the planes is possible or no in tongue. Jaw can be retracted or protracted jaw. Some cases they have protracted jaws. In some cases they have retracted jaws, and the jaws are not normally aligned with your temporal bone. This is your temporal lobe and your temporal bone. Your temporal bone and your jaw should be properly aligned. If they are not aligned, then mastication becomes a problem. The child cannot chew well, and gradation issues can occur. Respiratory functions, because breathing and swallowing go hand in hand. If you are not able to breathe when you are swallowing, because there is a brief amount of expiration and breathing pause that occurs when you swallow. When you are swallowing, there is a slight amount of extended expiration that occurs. If that is not attained in a child, if the inspiration and expiration are not going hand in hand with the swallowing, then there again feeding and nutrition will be affected. So we assess even the respiratory function in a child. How do we assess the respiratory function? We use measuring tapes and we put it above the chest level, at the chest level, and below the chest level. There are different markings, like at the above the chest level it should be 2 inches, at below the chest level it should be 2.5, and under the chest level it also should be between 2.5 to 3. So we assess their breath and assess their chest expansion with the measurement, along with the measuring tape, to see if the child's expansion and inspiration and expiration are occurring or not. Inspiration is an active process, but expiration is a passive process. You're not putting in a lot of effort. In cases with CP, even Duchenne's muscular dystrophy, we are not discussing that, but I'll just mention it. When Duchenne's muscular dystrophy is a case in which there is extreme muscle loss and severe weakness, and there is a respiratory failure eventually. So these kids, their nutritional aspect is covered in greater depth when they are in their palliative stage. Palliative stage is when there is a terminal stage to their life and they are wheelchair bound. At that time, they cannot breathe in properly. So what do we do is oral intake becomes very challenging because they're not able to breathe and swallow at the same time. At that time, we introduce enteral or parenteral gastrotomy tubes. So you must have heard about PEG tubes. That is parenteral gastrotomy tube. That is, we put it directly in the stomach and feed them, or nasogastric tubes, ET tubes, nasogastric tubes, so that the nutrition intake can be maintained through their nose. These are some things that we do in the terminal stages of a child's life. But otherwise, respiratory function is taken care of with respiratory exercises, which I'm covering. So oromotor intervention. What does a PTOT look at when we are talking about oromotor intervention? A big part of it when we talk about from nutrition perspective is positioning. We look at pelvic stability. So this goes without saying that your entire weight of mass is concentrated on your lower lumbar spine. That is your sacral vertebra. That is your buttock area. That's where the development has to be very good so that your trunk is erect. Your neck has to be maintained straight. So these children, we know children with CP usually have head lag, who are in the later part of who have a poor developmental milestone or who do not attain their milestones as well as you would expect. Not all CP children fall under this category, but some do. They are dystonic. Dystonic means tone fluctuation. So they have intermittent episodes of head lag. They do not have a continuous head lag. So in these cases where they have head lag and the trunk is falling, you can support it with straps. So I've shown it here. In the one of the videos, I did not get a chance to show you, but the child is, we have seen this picture where the child is leaning on like this on a chair. So you can actually support it with a neck pillow. You can have a pillow around the neck so that it is supporting their child, or the airplane pillow. You can strap the child to a CP chair so that the child is maintaining his trunk erect and his back is supported, and the hands are resting on the table of the CP chair. This helps the child to feed and swallow correctly because the head is in alignment with the neck. Okay, so trunk control, head control. When you look at trunk control and head control, your jaw stability is going to come into picture. Your jaw is going to be stable, is not going to be keeping on moving. Talking about positioning with respect to ADHD kids and ASD
Dr.
kids.
Rajisha,
Yeah.
sorry to interrupt you in the middle. I know
You
it's
can't
very.
hear me.
Can you hear me?
I can hear you. Can you hear me?
Yes. No, I'm
Okay.
sorry. I'm interrupting you in a very important aspect that you're sharing. I'm sure this is important, but can we do a little bit of more experiential conversation and sharing, because maybe that would be more helpful for people.
Right. So I have obviously seen cases where cerebral palsy children have had feeding and
One minute. Sorry. Sorry,
yeah,
sorry. 1 minute, dear. 1 minute. I'm
yeah,
sorry. What I'm trying to say is we have a mixed group of people here. There are some students as well. There are some people who are coming from, other backgrounds as well. They
of
want to
course.
know how they can help or how they can know a little bit more. See, understanding technicalities, yes, it's important, it's necessary for us, but within the short span, if we can cover more of experiential information, and if, for example, I'm just a common person, okay, and I
Right.
come to know that I have a parent or a child who's a parent who's handling such a child,
Right.
what is the kind of information I should be able to share with them, or a thought that I should share with them? So if you could give us that kind of little
Yeah,
bit,
so
or
if I
run
am
through your.
able to see, of course, if I'm able to see such a child, I should be able to tell the child, since students are also involved, I thought that I'll bring in a little bit of sensory component. But technical component. But what I'd like to share is when you are a friend of a child, a friend of a parent who has such a child, or you're seeing such cases in your day-to-day lives, there are a certain interventions that we as PT, OT can help them. And those are, of course, as I mentioned, you have to look at a holistic approach. You cannot, first thing that you tell a parent is that you have to involve a team. You send them
One
to a
second. One
yes,
second. Can I interrupt? Otherwise,
yes,
sorry. So, Archana, otherwise, can we take
case studies.
the parents who are here and they were discussing the cases?
We can
We
do
can
that.
discuss that and it will become a more practical approach.
Yeah, cases, but then, ma'am, again, if it goes deep in, then it becomes like a consultation session. Then,
Yeah.
other people will not be able to benefit. So,
Correct.
yeah.
What do
So,
we
You
do?
can
like,
ask me questions. We can take Q&A directly. If
let
that's
me
okay.
let me ask you the questions here. Okay, so
Yeah,
some of
yeah,
the
yeah.
questions and
Yeah,
about
that's
is,
better.
um, you know, so having now as a parent or as an individual who is having a child with special needs, if I want to approach this, nutrition aspect of my child, so I should not just go to a dietitian and just take the diet, but I also need to consult a physiotherapist who manages the oral physiotherapy activities in order to
Exactly.
get an entire alignment. Is that right?
Absolutely correct. You have
So
to get the picture.
a team approach must be seen, right?
Yes, even if you,
Right?
I'd like to add here that even if you see that your child is not having issues, you wouldn't know as a parent. You wouldn't be able to assess. You will be able to tell us the behaviors. You wouldn't be able to
Correct.
tell where is the problem area. So, in order to for you to identify the problem area, it is very important you refer them to a therapist because they will be able to pinpoint it. आपके बच्चे में ये issue है and communicate that with the dietitian. Assessment, yeah. And
Correct.
only when a therapist is able to communicate with a dietitian can dietitian give an appropriate diet, right? We are not talking about labeling a child. We are looking at clinical signs of the child. And for a parent, it is difficult to identify. Coming to that, addressing your question, why you had asked Sushila ma'am about why are these ADHD kids and ASD kids diagnosed in adolescence and not earlier, right? If you don't mind, Sushila ma'am, can I address this question?
Sorry, can?
Can I
Yeah,
address this
please.
question?
Yeah.
So the thing is, I have seen in my practice a lot, and I deal with 2 to 3 children who are adolescents and have come to me in adolescent only age group only. This is because of several factors. Now, when the child is born, autism is an autism spectrum disorder. It is not autism. Autism is a part of ASD. There are several categories of ASD. When you go into Diagnostic Statistical Manual, that is DSM-5, doctors use this to identify if my child has autism or no. When the child is born, there are red flags. The child will not give you eye contact. The child will have hypersensitivity or hyposensitivity issues. In India, especially, not everyone is aware. We are bringing in awareness right now. We are talking about inclusion right now, right? In those age groups, now the adolescents are coming to us as 13 and 14. When 10 years ago, if you talk about it, we wouldn't know about awareness and inclusion as much as we do right now. That is one of the targeted things. Pediatricians, even if they notice it, so for parents to identify the behaviors was difficult. That is one thing. If it is very well known that their speech can develop. Children with autism can develop speech. Though later, तो हम क्या बोलते हैं, मेरा बच्चा भागता है, सब करता है, माइलस्टोन सब बराबर है, लेकिन बोलता लेट है, बोला लेट है वो. I have seen cases right now in my vicinity who are 2 to 3 years of age group, 3 years of age group, and still talking in only two-word sentences. 5 years of age group talking in only two-word sentences. At least a 5-year-old, I will expect him to talk in 4 to 5 word sentences. With grammatical errors is okay. But parents are not aware. That is a major challenge. Lack
I'll
of
say,
awareness of parents.
sorry,
And
sorry.
pediatricians, yeah, I'll just finish. The second one is pediatricians give the children a chance to grow. They give the children a chance to grow. The team approach and multidisciplinary approach awareness is coming right now. So for us as healthcare professionals, it's very important to reach out to every part of that circle that I showed you. We have to collaborate. We have to go to a pediatrician and explain them, no, you send the child early to me because early intervention is important. If I look at the child in early stages of life, then he'll grow up to be good. But adolescent age groups, unfortunately, they miss this part. That's the thing. That's why they come to us late.
So as Rajisha said, for example, parents are probably not aware. So the first kid I remember I saw, the first kid, 4-year-old overweight CP, cerebral palsy. And when I was taking the history, खाती है, ऐसा तो कुछ problem नहीं है. Now when you go into the detail, friends, please listen. Morning when she gets up, 4 toast, bada wala, in a bowl of milk. Daba ke, the mother sits with her legs spread and keeps the child ulta like that. And aisa, feeding. Done, 10 minutes. Then get ready from far away come for therapy. By the time you reach home, it's 2 o'clock. 2 big chapatis, Maharashtrian, bowl of milk, mash, legs ऐसा रख के खा लिया, 10 मिनट में खाना खत्म. And the dinner at 8 o'clock was similar. So as what Dr. Rajisha said, at times parents wrote, so mother was very contented. Till the therapist it is becoming difficult for us to do therapy, for you to carry.
Yeah, awareness.
First and foremost is awareness. Like, that's very important.
One thing I'd like to add is I am seeing a child with a sensory processing disorder. He eats like this, but he eats everything and he is perfectly built, but he eats with an open mouth posture. He's 6 years old. He eats everything. He gags in between. He has difficulty eating dry fruits. Dry fruits he wouldn't eat. मतलब वो almonds नहीं खाएगा, kaju नहीं खाएगा. He will only eat good foods. Finger food is okay. Junk food is okay. All of the hard textures is not a problem. Taste is a problem. Even hard texture to some extent, but he eats like this. So I spoke to the mother. I told her he eats with an open mouth. He is not closing his mouth. He gags intermittently. These are all the signs. She said, नहीं नहीं, but वो तो सब खाता है. उसका कोई problem ही नहीं है. Because I wanted to refer her to Sushila ma'am. So that's what she told me. She's like, नहीं मुझे नहीं जाना है क्योंकि मुझे तो पता है उसका कोई problem नहीं है. So for us, it has become a big challenge to convince the parents कि छोटे छोटे signs दिख रहे हैं लेकिन है. Now a child with who knows, parents are also educated. They are immensely educated. They do their research, and it is very commendable when a parent comes to us with knowledge. But when a parent has not read enough about it and is seeing a seemingly normal picture of the child, at that time it's a challenge for us. Otherwise,
acceptance of the problem, existence of the problem itself.
Yeah.
I'll say one more point here because she said dry fruit. I remembered one mother. 8-month-old baby. We had to increase the weight. So I said the dry fruit, grind and keep it and put half teaspoon in the porridge that you're giving. 1 almond I give every day. She was very proud of what? Well, I don't know what is it called. On that stone, you rub the almond and give that paste. I have heard she will improve if you give 1 almond like that. So friends, the mother was not ready to change to almond powder. You got it? That is what actually we wanted to communicate to you, that a lot of understanding is required. And then I said, okay, you continue. So sometimes we also, theek hai, at least something else which is little more important, let her start following.
But basically, ma'am, what you both are probably sharing here is, the transition that one family or a parent has to make from conventional unaware situations to coming to, aware, mindful, nutritious plans for the child. So that entire transition is what people like you and Dr. Rajisha are,
That's
helping
what.
people go through.
That's what
And
we
it
were.
is more important. Like one question I really that keeps swapping my mind all the time is, even as normal family, so-called normal families, if somebody wants to go on a diet, like I know in my household, if my husband ever had to go on a diet, he'd be like, "Acha, main sirf na aaj khichdi aur salad khaunga." And I'd be
Yes.
like, why should I cook for everybody? So everybody has khichdi and salad, So does that also happen, in your cases? Because if the child has to have something specific, something clear, then it becomes very frustrating because the mother specifically in the household, even if she has a help to cook and everything, it becomes like too much of a mundane job. So so
I
does the family change the diet for a child?
Absolutely,
Is it
absolutely, absolutely. So this 1 year old kid, for example, she has an elder kid. I told you, na, who within a week's time said that it's just delayed milestone.
right?
Within a week, कुछ भी weight नहीं बढ़ा. 6.7 था, आज भी 6.7 है. I said, dear, you have to have patience. Now what happened is, so in this case only, when you're saying like this, so though I have given her the day's quota, that's see rice, 2 tablespoon raw, this, whatever. But when we did a video call and we explained, I asked her to keep all the bowls with her. So I said, घर में जो सब्जी बनती है, घर में जो दाल चावल बनता है, so that 1 tablespoon of raw rice is equivalent to this much of your cooked घर का चावल. तो आप टेंशन मत करो, आपको बेबी के लिए अलग नहीं बनाना पड़ेगा. So that also we have to take into consideration. Now there is another mother for a 3-year-old. Once again, I must say 2 hours assessment because child is not gaining weight, and on my table, she spread the newspaper and 4 leaves of palak, 1 inch carrot, 1 potato, 1 inch, blah, 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 whatever she puts in that soup. 3-year-old, why you are giving thin soup like that? How will he gain weight? You got it?
Yeah.
So I had to tell her, I said, all with due respect, but many a times too many things are in the mind of parents also, and they feel this is nutritious, so I must put. Now this 1-year-old, what she has started doing, her mother, what she has started doing, she's still continuing Cerelac twice a day.
Oh,
I'll also add one thing to it. Like I was seeing
So
lately.
so unless we do regular recording follow up. So first is, friends, what we were trying to tell you was understand the physiological and sensory issues.
Yeah.
So the requirement, which is very theoretical, but a lot of practical exposure is needed for us to do 200% justice.
Absolutely.
right. And ma'am, what happens also is, see, I know as an educator, I have met parents. It's not easy because they are going from therapist to therapist to therapist. Sometimes
Absolutely.
some children have to go through 3-4 sessions in a day. Speech therapy.
Absolutely.
So there, how can one? So do you people like you create that record sheet for them? Do you help them
Yes,
do that, or they
yes.
have to
We
do?
do. We do
Yes,
it.
no.
You
We ask
make
them,
that
how often is your speech therapy? What are the timings?
all that.
Okay, how often is your this? So Monday, Wednesday, Friday, you're coming for physiotherapy at this time, which means prior to this, you can do this, or while you are traveling from one center to the to back home. It is at times I have come across parents have to travel 1.5 hour
Yeah.
because they believe in that center. तो 1.5 hour गाड़ी है, driver है. So carry this item. But tomorrow when you're going for this therapy or in the school, I have spoken also to the teachers at times. Spoken to the healthcare professionals who are also taking care.
Right.
So that multidisciplinary approach is very important. In fact,
Ma'am,
I'll just finish Sorry.
Sorry, we are kind of running out of time. We have also Saraswati ma'am here, right?
I'll only answer Gemini's question on ammonia.
Yeah.
So Gemini, if I'll share my number with you, I would like to know a little more about what is the reason ammonia. You have written about the tablet. So have you spoken to the doctor? What was the diet prior to that? I need to a little bit understand, and then I can really answer whether protein has to be restricted in the diet or no.
All right, ma'am. No issues.
Yeah, I'll share my number if you. I'll write here, and you can take my number.
Okay.
We'll
Can we
start
have
with.
Saraswati ma'am here?
Yeah, she's already there.
Rikisha, can you get Saraswati ma'am and spotlight? Saraswathi Sriram. And the students also, please. Thank you so much, ma'am, for enlightening us with, one is where Dr. Rajisha is saying how the systems work. The second is how the thing that goes into that system works. So we've had both the information right now. So, I think now, yes, we have Saraswati ma'am here and the students as well. So let's introduce Saraswati ma'am.
I said, Archana, I know it was a theoretical thing, but we just felt that we want to give.
Absolutely, ma'am. Absolutely. No, I completely understand. See, this is also, to be very frank, I'm sure the participants will also agree. This is the first of its kind that we are taking an effort to try. I'm sure from this learning, that's why we want people to give a feedback so that from this
Feedback
learning,
is very important.
curate a better program so that they can be part of that learning, in the actual sense. Yeah. Thank you so much, students. Yes.
Good afternoon, when not present.
Aditi, sorry, louder better.
Good afternoon, one and all present. I here introduce you all to our third speaker for the day, Ms. Saraswathi Sriram. Ma'am is the founder and director of Mahayoga Wellness Center. She is a yoga teacher and evaluator certified by Yoga Certification Board of India. She has done her MA in Yoga Shastra. She is certified in yoga for children with special needs and she is a life coach. Ma'am, we are lucky to have you here. Thank you. Ma'am, you are on
Thank
mute.
you so much, Aditi. Yes, ma'am. Ma'am, you need to unmute yourself, please.
Yeah. Namaste. Thank you, Aditi, for that wonderful introduction. And thank you, Archana ma'am, for having me here. And I would thank Sushila ma'am also for this, introducing me into this. That as we said, the topic is yoga for children with special needs, right? So we will just go one step before, okay? So right from the babies in the garbha. Actually, since I'm a yoga teacher, I will be relating more with Ayurveda text and yoga text. Okay, so there is one book, Upanishad called Garbha Upanishad. Okay, it was written in the year 1000 year BC, and there is one more book called Shushruta. Okay, somebody says can't hear. Somebody is saying can't hear. Can you all hear me? Am I audible?
Yeah, we can.
Yeah, because somebody says can't hear.
No,
yeah, we can
now
hear.
it's audible.
Yes. Yes, it's audible. Yeah. So as I was saying, there is one Upanishad called as Garbha Upanishad, which is a full study of embryology. And there is one more book called Shushruta Samhita. Okay? It is an Ayurvedic text. It is written in the year 700 year BC. Okay. In that, in the third chapter, it is clearly mentioned about the fetal development. It talks about
Saraswati ma'am, 1 minute. Saraswati ma'am, Archana, till what time can Saraswati continue? It's 1:15 already.
Yeah, we have like 15 minutes, and if participants, we have had people being kind enough.
I'll finish up
Yeah.
my explanation in just 5 minutes.
No worries.
15,
I
20
just thought
minutes.
I'll
Yes,
ask
yes.
you
I'm
then
sure
accordingly you.
participants won't mind, ma'am. Ma'am, if you make them do some exercise, I'm sure they will sit.
They will do. And just to tell the participants that in 2017, we did yoga for special children. So we got more NQ into it, and we thought, let us share that concept also with you.
Yes.
Because
Yes,
mostly
please.
people must not have heard. So Saraswati
Yes,
ma'am,
please.
just couple of minutes of intro, and then as we discussed, you can
Yeah.
start making
I
them
just
do.
want to show you that we have a proof in yoga. I'll just talk about those two things and directly we go for practices, because all the problems and all have been already talked about by our expert, nutrition expert. So I'll just say these two things. In Sushruta Samhita, it says that in the 4th month, the heart of the fetus develops, and through that, the fetus connects with the mother. And you must have heard about the mother saying, मुझे खट्टा खाने का मन करता है या मुझे मीठा खाने का मन करता है. So all this comes from the fetus. So we should try level best to satisfy the needs of those fetus. Okay, and sometimes the mothers are not that much aware, right? We are not able to listen. Would-be mothers are not aware, and they are not able to listen to communicate with the fetus. So what happens when the needs are not satisfied? Sometimes the defects happen in the child while during the birth. And when do we come to know? When the milestones are not achieved, that time we come to know, oh, there's some problem, and they go and consult a psychologist and psychiatrist and nutritionist. Right? So in here, what yoga helps, in Hatha Yoga, in first chapter, it is clearly mentioned. Yuva vriddho ati vriddho vyadito gurbalopi va abhyasa. Okay? And siddhi mapnoti sarva yogesha tandritaha. That means anybody can practice yoga. Whether you are young, old, very old, or vyadito, even if you are diseased, then also you can practice yoga. And even if you are debilitated. So that is what we are coming here. I just wanted to show you the proof. Even if the child is in a debilitated condition. And there's one more thing which I wanted to mention. I don't know whether you might have heard about Patanjali. He's the father of yoga. In the sutras, the 5 states of mind are mentioned. One is Muda, Kshipta, Vikshipta, and then Ekagra and Nirodha. So for these children, we will be dealing with the first 3. That is Muda, Kshipta and Vikshipta. Okay, Muda means dull. Kshipta means they are totally distracted. The mind is in the distracted state. Kshipta. And Vikshipta, they are partially distracted. So these 3 states of mind fit. So that is how yoga can work here. So I won't go further explanation because about the problems you have already heard. So I only wanted to give you the proof. It is possible to help these children through yoga practices. Okay, it is possible to help, and we cannot expect any miracles. Our main idea for doing yoga is we can reduce the response time. For example, not only in yoga, even in their daily activities, they need to follow instructions. We had an, I'm sure even Sushila ma'am would agree, we had a yoga session. When we start with Om, there was only one child. We all finished saying Om. After 10-15 minutes, that child is saying Om, just out of the blue, randomly, he says. That means he has taken that much time to process one instruction, that chant Om. So we will not expect any miracles, but we can reduce the response time and other issues like, the spine. These children, they are not able to do simple tasks, or they are able to do simple tasks, but with lot of effort. So they exert themselves a lot. Because of this too much of exertion, what happens? Their spine becomes stiff and it leads to pain, back pain, and the movement becomes restricted. So yoga, we will be handling these things. Okay. So what practices I will be showing now is for few practices for Down syndrome, 2-3 practices of cerebral palsy. But I'm combining. It is going to help in a overall development. So I'll be combining and then I'll be doing. Okay. So everybody can join. You all can even switch on your video. Since we are falling short of time, I won't do the explanation much, but we will directly go for the practices. Now, we can help the children, of course, if If their lower limbs are not affected, they can sit down, or they can even sit on the chair and do the same practices. But today, since we are falling short of time, I will only show when the lower limbs are working. So I'll show you only that part. Okay. And such children, you cannot expect any perfection. Forget these children. Even sometimes today, we are not able to do certain postures perfectly. So even if they make an effort to do that posture, that itself makes a big difference for them. It is a big achievement for them. So we should help them in doing such postures. So the first one is for the blood circulation. So you can just spread your legs like this. You spread your legs like this, and just you can just help them. You should make them do. You should not do it yourself. Or in case they are not able to do it, you can just hold their hand, and but they should do it themselves. Okay, they should massage this. So first and
All
foremost,
participants who want to practice this directly, please do it at your respective places.
parents can join, please. If your child is also joining, nothing.
Parents, if your child is there, you can slowly do on.
Nothing like it. But all the
Also, just to add here,
even the
just
teachers
to add
can
here,
join.
Saraswati, as we had said, I'll just, you continue.
Yes.
What you can do is sing some poetry. What we learned was singing poetry, and you can make them do.
Yes, if the child is not able to do it himself, you should hold his hand, but you make sure that he does it himself. So
We
that
have
he comes
Mr.
to know
Jude, music
that next time
therapist.
he is given an instruction that he should do it. Okay, and likewise with the hands also. Okay, for them we have severe blood circulation problem. So when you press, all these blood vessels are there. So especially in the legs where the veins are ending, there you need to press more. The problem is the venous blood is sometimes not going back into the heart. So you should make them press on their own. They should apply. It's an exercise for them because they are using their hands, right? So this is for improving the blood circulation. And the next one is you need to give them a blood circulation towards the brain, towards the head. So you can make them sit like this. Yeah, you can tell them, parents, you may please join, and you can ask your children also to join. So you have to tell them stories. Like you cannot teach them yoga as though you're teaching to adults. So you can make them sit in the cat position and say, oh, this is a cat. And what does a cat do? Then you have to say meow. So you should also say meow with them. Then only they will listen to you. Meow and meow. See, as I said, the first problem they have with this spine. The spine becomes stiff. So we need to address that issue. Otherwise, we won't be able to do any other yoga. So you have to say meow with them. Meow, meow, like that. Different sounds you have to make. Okay. Then you say a cat is there and a dog came by. Then you have to sit like this. And you have to keep your hands like this and tell them that you have to open the tongue and do what does a sitting dog does? The dog is sitting and it is watching the cat. How does it watch? Like this. This is very good for seizure, epileptic seizures, and they get such children. You should give them practice because we want to throw the toxins, carbon dioxide out. So you should put out the tongue and then say, such things you should do. Right? Then the next one which I would say is, in case
Yojana is participating in the yoga with you. Yojana, sorry, Kimaya.
Okay, please keep your video on so that we come to know.
Can we have Kimaya on spotlight, please?
Yes. So I get a good demonstrator also, and we can practice also. Okay, so you should do like this. When the child is bound to get has a tendency of seizure. Now, when it is in the case of cerebral palsy, the center is in the cerebellum, correct? So what we have to give them more of balancing posture. Okay, then you can talk of a tree. That time you can stand. This I'm just showing you a sample so that you come to know, and very limited time. So what we'll do, then make them do asana. Asana is a palm tree. So make them and then stretch yourself. Yes. My view is still there.
You see her?
Can you see me? I'm here. Can you
I
see
can't
me?
see Saraswati ma'am. Can others see her?
Can others see me? Please give me a thumbs up. Can others see me?
No, ma'am. Your video is like paused in
Okay,
a
okay.
particular.
Yeah. Just a moment. Yeah. Just yes. Yeah. Now can you see me? I've switched on my.
Thank you, Kimaya, for joining in. So motivating. You're really the star.
She enjoys doing yoga.
Amazing, amazing.
It's really good to see somebody doing it.
Yeah.
Awesome.
Oh, she's a very, very active personality. You will see her on 24th. She's
Oh,
one of our
yeah.
speakers.
Great. That's awesome. Great.
Has Saraswati ma'am joined? Can we have her on spotlight?
She has got logged out.
No, she's logged in. Unmute her, please, and put her on spotlight. Thank you. We surely have understood that we need a very, very good one-day session on nutrition and health. So now that we have done a premiere, abhi hum bada film banayenge. So we have promised all our speakers of all the sessions that every day the sessions are looking so less, we need to have more. Saraswati ma'am, please switch on your video. Vikisha, could you help her with that? Video and audio. Again, she's logged off. Maybe some network issue. So, Kimaya, why don't you show us some yoga moves that you do till then? Come on. Yojana, you could do back camera for her.
Yeah.
Lovely, lovely, lovely. Oh my God.
Wonderful.
God bless. You're doing a fabulous job.
Whoa.
Oh.
Wow.
Great.
Oh my God. Hold that. I'm taking a picture. Kimaya. Seriously. No, I'm not getting a full picture of her. Yojana, you need to show her fully because I'm only getting her feet. No. You go back and show her fully.
Yeah.
Oh, lovely. Lovely, lovely.
So this is Pavan Muktasan, wind releasing pose.
There, Saraswati ma'am has come.
Excellent.
Oh my goodness.
Saraswati's net is never a problem. I don't know what happened today. I've been attending her yoga classes. She takes normal yoga classes also.
Yes, ma'am. Yes, ma'am is on. Yes,
Yeah.
ma'am.
Yeah. Can I go to the next practice?
Yes, please. Yes, please.
Yes. Okay.
Thank you, Kimaya. Thank you.
Thanks, Kimaya. Wonderful job.
Wow. Clap, clap, clap.
I think she could also take a class. It's that great.
Oh, this is lovely.
Wow. Kimaya, since how many years you are doing yoga? आप कब से कर रहे हो बेटा योगा क्लास?
Yeah, tell. My yoga miss taught me. Yeah, she had yoga in school also.
Wow, superb. I thought only we know yoga. Very nice.
Great.
Saraswati, are you there? Archana, you are on mute.
Yeah, so I'm not sure if ma'am is able to join because of network issues. Do you want to come?
Basically, yeah, I can tell little bit, but whatever she wanted to do, it would have been good.
Okay. Archana ma'am,
Yeah,
can you?
maybe
So
share
one
some
is that typically when we were talking about ADHD and ASD, so it's more of calming the mind. So we do what is called either Om chanting or Brahmari pranayam. So most of you must have heard about Brahmari pranayam. Either you put the index fingers in the ear or you can close all your senses. How you do, Kimaya? Very good. Yeah, we'll close all our senses. So everybody please do till Saraswati ma'am comes. Okay. So the skin sense, eyes.
I'm really so sorry about that.
Okay, okay. Saraswati
amazing,
ma'am has come.
amazing.
Yeah,
We could all do this.
continue.
Yeah.
This
Yeah.
is very good. Saraswati ma'am, just continue on Brahmari. We started that.
How do you do it?
Anji?
Yeah, okay, okay. So on Brahmari pranayam.
How do you do it, ma'am?
So Saraswati is saying, otherwise I'll finish it.
Ma'am, you go ahead. You go ahead.
Okay, so 5 senses we need to close and be within ourselves. Okay, your entire concentration will be on humming sound.
Yeah,
so,
yeah. I'm coming to the
nose and lips and the ears. Take
Yes.
a deep breath. Everybody repeat one more time with complete awareness within your body. And breath. Take a deep inhalation.
Now, what happens to children who don't get, so somebody else can do it for them?
No. Then you can just even keep the hands like this. That's I was coming to the next. Since Kimaya is in front of me, I took the one that everybody can do. So what we can do is, where is Saraswati?
Ma'am, I don't think she's logged in, ma'am.
Oh God, she came na in between once. I don't know what
No,
happened.
some network issue. She's
Okay.
coming and going.
So you can keep the hands like that in your lap also. Simply, you can do that. You can even keep basically
like this. One on the other.
Yeah, one hand on the other. You can do that also.
You're doing such good Padmasana, my God.
Why I did this is like autism and ADHD, generally, they will be able to do it. Unless like CP and all kind of kids may not be. So for them, we have different yogic practices.
I actually do these in my sessions every day, the Brahmani pranayam and even the meditation. It calms down the kids with ADHD and ASD. We devote
It
10
calms
minutes to
them.
meditation.
So what happens in an indirect manner, it benefits them. So it calms their mind and definitely helps in reducing their hyperactivity, and then even their food intake improves. So food intake, acceptability, performance. So yogic practices are in that manner, helping us. But of course, it takes time. So another one, if I can show you, I'll have to sit down. Butterfly, if everybody can sit. Again.
Oh, there she is. She's already flying.
Yeah.
Yes.
So butterfly, like this, and then we can sing a poetry for them. Butterfly, butterfly. Then they enjoy it. So different kind of yogic practices. How she did Pavan Muktasan. So that helps in your lower body muscles. Then if there is that gas, constipation, all of those issues, because you're pressing on your tummy. All right. So there are various yogic practices.
Thank you, ma'am. Thank you so much.
No, Baba. I am feeling bad for her, and now because we are
No. We will surely come back for a bigger event. Don't worry.
We both did normal yoga course of 2 years from our institute, and we both did special yoga course from the same institute in the same batch. But now I just saw the time, it's 1:30. Unfortunately.
Yeah. Ma'am, we need to have some concluding notes. So just, before
So
the...
if I can conclude.
Yes.
I can conclude. One is, if you want, I can share with them so whatever was a trailer today, we have designed a course on nutrition for special children, which can be registered. I'm not again logging in, sharing and all that screen. So for healthcare professionals, parents, they can also, this is also very good what Kimaya is doing. Excellent. Basically activating all your key points. Very good, very good.
Amazing.
So we have that
Yeah, keep her on spotlight.
Yeah, she's on spotlight only. For Acha, I have pinned her video. So that is one. And secondly, whatever we spoke, yes, it was mainly to understand that if I look at it, the dietitian's perspective, that it's not just planning the diet. The CP kid has come, age ye hai, and height, weight is this, and I give so many calories and so many protein. No, she has to interact with the physiotherapist, take all the inputs from her, and then only plan. If there are physiotherapists and occupational therapists, they should realize, and psychologists and special educators, all the healthcare professionals, that as soon as the mother is also complaining, or when you do evaluation, so probably, you can incorporate as a part of your evaluation, oromotor evaluation, and take a call on whatever red flags Dr. Rajisha showed, and refer to the nutritionist. The progress will be better if you start with the child from the time the child has entered your clinic, rather than somewhere midway. All right. So that's the second thing. For the parents, you are doing your best. You saw my talk, the first slide was what? They do their best, no doubt about it. And of course, we know, as Archana ma'am said, they have to go from one therapist to the other therapist to pediatrician and neurologist and so many doctors and all they have to visit. So a team approach would definitely help them, And for such conditions, we have to have that patience that it'll happen. It'll happen. As I told you about this 1-year-old kid, I could send the chat of the doctor to this mother. So day before, after sending the chat, I called her up. I said, you understood what message I have sent you. So giving them kind of a consolation. We are here to be with you. And it will take time. We have to have patience. I think that's all I would like to say. Dr. Rajisha, if you want to say something more, please.
No, of course, I think what I want to applaud Dr. BMN College of Home Science and Mrs. Archana and the team that she has, that they took an initiative to bring an awareness. We have very limited programs where guests are called upon, and it is a 7-day program where everybody is involved and you're touching on every aspect. So tomorrow I see there is Dr. Harish Batigar from physiotherapist team who is going to be on an expert panel, and I already had a conversation with him. That was so glad to see him. This is my second or third time giving a talk in a college, and it was a wonderful experience. A little sad that I could not include the intervention aspect in detail, but maybe we can connect again in future and it can be covered in greater details for the aspiring students, especially because I think they're the future healthcare leaders for tomorrow, and we have to empower them. They are the major team right now. Students have to be taken care of, because I know when I was studying 5 years ago, had I been a part of these awareness programs and inclusion programs and attended the lectures, I would have got the knowledge prior than being practicing and getting that knowledge. So I got the knowledge when I was practicing, not when I was in college thoroughly. And it is wonderful that students are attending this. So a big applause to you for this and carrying it forward. Yeah, that's my concluding
so much, Dr. Rajisha. Thank you, Sushila ma'am. Thank you, Saraswati ma'am. Sorry, Saraswati ma'am. I think some difficulties, but we are here to overcome those barriers. So I think this entire initiative of including you is to break the fear that we have barriers to break. So our entire approach. Yes, today the participant list is it started at 60. Yes, today if you now see it's 26. Little saddening, because we want we want that we reach more people. But I always, yesterday I was talking to somebody, and I want to share the starfish story. So, like I told yesterday also in the meeting, that when this girl is throwing one starfish which was sent away by the high tide onto the shore, and it was all looking dead, and she just kept putting it back and putting it back and putting it back. And this man walks in and says, "Arey, what are you doing? They're all like dead. They're all washed off the shore. Why are you wasting your time doing this? Why are you putting the starfish back into the ocean?" She said, "Even if it makes a difference to one starfish, that's what I'm doing. So I'm doing my part." So I think as a team of Cheerful Connect, and as Dr. Beeman College, who's really been, grateful to give us this opportunity. And like all of you have taken your time and effort and experience to come and share here. I think I really, really wish to applaud each of you, because I'm sure out of all these participants, there is this one starfish which we have helped. And I'm sure about that. I'm very sure about that, because it never goes, waste. It never goes waste. And this, including you, is an effort. We are going to continue this effort. And like you rightly said, Dr. Rajisha and Sushila ma'am, that we would like to have more such programs and continuous programs at different levels, maybe bigger ones, eventful ones. And we would like to include you all in that as well. And thank you so much, students, Tanvi, Aditi, and Riddhi, for always being this strength since the time I started this, Cheerful Connect initiative of this event. And my friend Monica is also here, but she's not able to connect because of network issues. So yes, so thank you so much for coming. Thank you so
Thank
much for
you.
sharing. Thank you so much
Thank you,
for
Archana. Thank you,
giving your
everybody.
valuable
Thank
input.
you so much. Thank you.
And we really wish you all the very best. And now it's, nutrition is done, health is done, exercise is done. Now it's lunchtime, so everybody's waiting to get back to their kitchens and their tables. So all the best to all participants, and please motivate everybody to join in tomorrow. We have a panel with Dr. Harish, Dr. Tanuja, who's a remedial educator and psychotherapist, and with Dr. Jyoti, who's an occupational therapist as well. And ma'am, you're also please welcome. I'll be sending you the details. Do join us, and please spread the word. We really want more and more people benefiting from this little starfish journey that we have.
Sure, sure.
Thank you. Thank you
you.
so much.
Thanks,
Bye.
everyone.
Good day, everybody.
Bye.
Good week ahead.
Good day to all of you. Good day to all of you.
Thank you. Thank you so much. Thank you, Archana. Bye.
Thank you so much. Thank you so much, ma'am. Thank you so much. Today we don't have Nitin sir.